Dear live, please.
So shall we start? Yes.
Yes, doctor.
Good evening, everyone. It gives me an immense pleasure to welcome you all to the grand finale of the prestigious competition. I'm Dr. Padmamalini Mahendra Das, President of the UVIETS Society of India. And on behalf of the society, I extend my warm greetings to guests of honor, respected judges, GC and EC members of USI, Next Gen Council members, USI members, dedicated participants, and a wonderful audience. Postgraduate training is a crucial phase in the shaping of the future of our specialty. Competition such as this not only promote academic excellence, but also inspire critical thinking, scientific curiosity, and meaningful academic interaction among the trainees from across the country. This year, we are especially delighted to introduce this national level PG competition, which we hope will evolve into a regular and prestigious academic event in the years to come. To support this initiative and ensure its continuity, a dedicated fund has been established for this PG competition. This will help sustain the awards and recognize deserving postgraduate students in the future as well. I would like to congratulate all the participants and wish them the very best. With this, I now hand over the proceedings to Dr. Partho Pratim Datta Majumdar, our Secretary of UVIET Society of India, and Dr. Vandana Pradeep, Editor USI Newsletter, to take this program forward. Thank you, and let us begin this grand finale.
Good evening, all. Welcome to the grand finale of the All India Postgraduate UVIETS case competition. This is perhaps one of the first initiative by any subspecialty society in ophthalmology to organize such a competition among the postgraduates. So this idea was conceived by our team, and our president voluntarily donated a corpus amount so that it can be conducted every year. I, on behalf of the UVIA Society of India, thank Dr. Padmamalini Mahendra Das, our president, for this wonderful gesture. We received application or the PowerPoint presentation from 107 postgraduates, and it was not an easy to screen and organize all these cases. This mammoth task was made possible by the Next Gen Council of USI, a group of members below 40 years of age, with their energy, enthusiasm, and eagerness to work for the society. I must say that they did a fantastic job. I would specially like to thank Dr. Ahana Sen, Dr. Molly Shah, Dr. Rakshita Kene. They coordinated with all the participants, took care of all the requirements. They called individually to 107 postgraduates. And not only that, they divided into the groups in a randomized manner to avoid bias while keeping in mind that who will be the judges in which session, and handled last minute changes based on the participants' needs. Someone had some work or some duty. So they managed everything and truly managed the entire show behind the scene. So now many postgraduates opted for a mentor to guide them, preparing for the presentation, how to present a case of uveitis, and our next gen members help them as a mentor and help these postgraduates in fine-tuning their presentation. Finally, the schedule of the prelims were structured and divided into two virtual halls, A and B, and in two sessions with 1 hour lunch break. You can see here that how we conducted the webinar in two halls and the time durations here. So finally, on the 8th March, Sunday, we conducted the prelims. This was the view from the secretary's desk. 99 challenging cases, and believe me, all of them were really good and very, very challenging, to such extent that the judges had tough time selecting this finalist. I'm thankful to all the postgraduates for their enthusiasm and interest in UVITS. I believe this will bring in many more young minds who will be interested in taking up the UVITS, who will be practicing the UVITS more carefully with more enthusiasm. And this will help us to increase the awareness of UVITS management, treatment, diagnosis, and most importantly, overall, it will help improve the care of the patients with UVITS. I have promised them that we'll definitely will come up with a small workshop on UVITS designed entirely for the postgraduates, so they can learn about the most common entities, as well as help this course will help them to excel in their examinations also. Now, my sincere thanks to Dr. Daivat Shah, Dr. Vandana Pradeep, Dr. Samayak Mulkutkar, Dr. Nitin Kumar, Dr. Navneet Mehrotra, Dr. Vijay Pratap Singh, Dr. Mayur Morekar, and Dr. Jogesh Kamath. Thank you for your time and insight and thoughtful evaluation. They were the judges who actually evaluated each presentation, asked the relevant questions, and finally help us to select the finalist. Now, moderating these sessions was not an easy task, especially each session was having 25 participants in each. And I sincerely thank Dr. Aditya Patil, Dr. Shrutika, Dr. Ronnie, Dr. Isha, Dr. Sara, Dr. Lisa, Dr. Saptab, and Dr. Atul, who actually not only moderated this session very nicely and handling the each participants, they're asking the judges and helping us to keep the time, and finally helping us with the final prelims. So now, to introduce the jury, we have Dr. Padmamalini Mahendra Das, who is the president of USI. We have with us Dr. Samya Basu, who is the chairman, scientific committee, and he also heads the UVITS services of the LBPI network. And let me introduce the chief guest of this evening, Professor Vishali Gupta. Professor Vishali Gupta is a vitreoretina and uvea expert of international repute, currently working in PGI Chandigarh, India. She chairs the only MCH training program in the vitreoretinal surgery at PGI Chandigarh, offering 3 years of dedicated training. She is the president of the International UVIT Study Group and the Vitreoretinal Society of India, and she was also a past president of the UVIT Society of India. She is the only Indian member of Club Jules Ganin and the first Indian member of the Macular Society. She is also the program chair of Retina at Arvo. She is a highly sought-after speaker, having delivered more than 1,000 invited lectures and conducted numerous instruction courses at national and international meetings. She has published 446 PubMed Index publication, has edited 6 books, and contributed 84 book chapters. She has an H index of 70 and more than 20,000 citation. She has several named awards and lectures to her credit, including prestigious gold medal by IUSG, Stephen Foster Lecture by Foster Immunological Society. She also holds 2 US patent, and she is rated as top 2% of world scientists in Stanford rating. Ma'am, we are honored to have you among us. Now, I would request you to address the postgraduate and give your perspective on the topic which I have allotted to you, why you love treating UVITs, and why it is so exciting and interesting. Over to you, ma'am.
Thank you very much, Partho, for the very kind and very elaborate introduction. And congratulations to Team USI, Partho, Padma, Soumya, for conducting this for postgraduates. And heartiest congratulations to all of 107 who made an effort to submit the case for uveitis. And of course, the 12 made it to the top, but everybody deserves to be congratulated equally. Partha told me just few things. I won't take very long to talk to you, like why uveitis. I don't think uh, I can actually tell you why uveitis, because if you want to do uveitis, it will come from your heart. It will be your calling. But what, as the postgraduates, and since we deal with the postgraduates all the time at PGI, there are few couple of things I would like to advise you. First is you will be seeing cases every day. Just do not navigate through the day. Make a mental note. Even if you make a mental note of one case per day, that what you have seen, go back and read about the day at the end of the day. What, for example, it could be optic neuritis, it could be granuloma, it could be retinal detachment, or anything which is unusual, which you are seeing for the first time. Don't let it go beyond 24 hours. Go back home and read about the case. And my second tip is, when you are reading about the case, just don't open any random book and start reading. Read about first the anatomy, the physiology of the lesion, then the book, and then, of course, you can read the journal to update what is the latest. But that will keep you very up to date on the case. And moreover, when you read the condition after seeing it clinically, you won't forget it. If sitting in the room one fine day you start reading about retinal detachments, diabetes, optic disc granulomas, anterior uveitis, it will be all theoretical. It won't have a mental makeup. But once you have seen the case and then read it, you will definitely understand it much better. The third thing which you can do as a postgraduate is to learn the basic science. I personally miss doing that. But I think PG is the time when you can learn about the technologies, walk up to the lab, show some interest. It's very easy, like all of you, I'm sure, in your day-to-day practice, sending KOETs, calcoflows, PCRs, and all those stuff. Walk up to the lab, see how it is being done. What you will learn from now will stay with you forever, and that's very important. The fourth is when it comes to treatment, and over the next 2 hours, you will see how complicated the treatment can get in uveitis management. Don't just treat the eye. Think that it's not the I which has come to you, it's a human being who's walked up to you. So treat him like a human. If you are penning down something, don't write a medicine till the time you know the side effects of the medicine, till the time you know how to read about it, how to treat, how to prevent those side effects. So please go back to your pharmacology books and just open it, read about it, so that you are not just treating because it's random. You are treating with a very knowledgeable, conscious decision, and you are watching out for the side effects. So many a times, you will have to go back to your old books of Robbins for pathology and for pharmacology, all the standard books to understand. General physical examination, especially when you are looking at the uveitis patient, that becomes utmost important. And coming to my last part, ask questions. This is the only time in your life when you can ask any question. You may feel it's stupid, you may feel people will be judgmental, but believe me, once you ask a question in any forum, whether it is one-to-one interaction with your teacher, whether it is your fellow colleagues, whether it is in the class or in the conference, and you get the answer, you will remember that answer for the rest of your life. If you just read something in the book, that you will not remember. The questions which come to your mind at this stage can be a lifetime mission or a research for you, and this is the time to develop it. I will give you my example. In when I was postgraduate, I had just joined, and my first question to my boss and my mentor and my teacher, Professor Amod Gupta, was that why are the eyes removed for tuberculosis? Why don't you make the diagnosis? Because there is such an easy treatment available. And he told me we cannot make the diagnosis because uh, we cannot get the fluid from the eye and the yield is very low and all those things. And he said, oh, there is something called PCR which has come up. Maybe you can try getting it. So I still remember the excitement. We took the sample. I took the sample myself to our immunology lab, waited there for almost 1 hour to see how the sample was being processed. And when the first report came positive, oh my God, I thought like I had won a Nobel Prize or something. And that is how my personal journey with tuberculosis started, with a very simple question. And I have done most of my work on TB, and then we went on to collaborative ocular TB study. But the seed was sown during my residency. The second thing which I hated was white dot syndromes. Believe me, till last 2 years, I just did not understand what was white dot because they were all so kitsch for me. Like, I'm a very black and white person. I get very confused in anything which doesn't have clarity. And I could never mug up the different conditions which were in white dots. I was told to present a seminar when I was a resident on white dot syndrome, and I tell you, I hated it so much that I thought to myself that one day I'm going to simplify these white dots. That day came much later in my life, almost 25 years later, because white dot is not something which we are trained in India, but fortunately, with global collaborators, I moved on to it, and we very recently came up with a very clear classification and suggesting to abandon the term white dots and treat individual entities, giving them the full respect. So, this is all what I want to say. Don't take yourself lightly. If you love medicine, if you have inquisitive mind, if you want to treat the patient, uveitis is the most beautiful speciality because I do both VR and uvea, and VR is like, it takes up 80% of your time, but it's just the macular hole and the PVRs and this. And I always feel, oh, if something my fellow can do, I don't have to spend my time on that. So my VR is on a very automated mode. They see the patients, they send the patient, they operate the patient. I'm just around helping them and intervening whenever I have to. And for my uveitis patients, I actually sit there and record history. And sometimes it takes me 45 minutes just to take the history, looking at the records and all, because every patient is challenged. Every patient is different. You think about it. You learn it teaches you humility. You learn to be humble. You learn how many mistakes you make along the way and then keep moving on. So it's a beautiful speciality, and congratulations to all of you and to team for bringing in the postgraduates. I'm sure all of you will one day be doing the area of this speciality you love to do, and we do hope many of you taking up UVIA. Thank you, Partho, once again for the very kind invite.
Thank you, ma'am. Thank you, Vishali, ma'am, for those wonderful, those inspiring words. I'm sure that has you have beautifully explained how exciting and how beautiful our subspecialty is, and I'm sure that it has imparted excitement to the postgraduates listening to us right now. So, um, moving on to the most awaited segment of today evening, that's the grand finale of the All India Postgraduate UVIEITS case presentation competition. Shall we start with our program? So, I'm calling upon the very first presenter of the day. She is Dr. Aastha Bansal. Aastha, please share your screen and you may start presenting.
Sunilji, please switch on the timer.
Yes, sir.
Please proceed.
May I start?
Yes, please.
Okay. Good evening. I'm Dr. Aastha Bansal here to take you through my case titled More Than Meets the Eye. A 21-year-old presented to our OPD with complaints of sudden, painless, progressive vision loss in both eyes since one day. She has a history of migraine for which she was started on oral topiramate 10 days ago. On examination, her right eye had a best-corrected visual acuity of 1/60 with a shallow anterior chamber and positive relative afferent pupillary defect. The left eye had a best-corrected visual acuity of counting fingers at 1 meter and a shallow AC. Noteworthy here is her myopic refraction in both eyes. Her IOP was elevated at 40 and 32 millimeter of mercury in the right and left eye respectively. Gonioscopy showed closed angles, not opening further on compression. Our provisional diagnosis was that of a topiramate-induced angle closure in both eyes. She was acutely managed with ocular massage, oral acetazolamide, and IV mannitol. Ultrasound biomicroscopy showed shallow angles and 360-degree supraciliary effusion, supporting our suspicion of topiramate-induced angle closure. Once her intraocular pressure came down, we went ahead with the full workup. Dilated fundus examination of the right eye showed dilated tortuous vessels, perivascular hemorrhages, and perivascular infiltrates. While the left eye shows a normal-looking posterior pole, and we can see wedge-shaped areas of ischemia in the periphery. These perivascular infiltrates of the right eye arouse suspicion of a vasculitis component. This Optos image gives us a better view of the peripheries, and in the left eye, the extent of ischemic areas can be seen better. It appears to be choroidal. OCT of the right eye shows subretinal fluid at the macula, while the left eye shows a preserved foveal contour. She was then started on anti-glaucoma medications to control her intraocular pressure. We asked for blood workup to rule out vasculitis, physician clearance to start steroids, and a carotid Doppler to rule out any vascular occlusion. At this point, we were thinking along the lines of a combined vascular occlusion in the right eye and an impending occlusion in the left eye. She returned to us 2 days later while we awaited the investigation reports, and we noted worsening of the fundus image in both eyes. The right eye showed an increase in hemorrhages and vascular infiltrates, while in the left eye, not only are we seeing hemorrhages now, the choroidal ischemic patches also seem to have worsened, now threatening the fovea. Her blood reports also arrived on the same day, which showed anemia, a raised ESR, raised CRP, and antibodies positive for anti-double-stranded DNA and anti-phospholipid antibody IgM. Our impression then changed to a secondary antiphospholipid syndrome, secondary to lupus. We sought specialist opinions who advised treatment with rituximab and intravenous methylprednisolone. She was then treated with 1 gram IVMP for 3 days, followed by oral steroids. She was also started on cyclophosphamide infusion as she could not afford rituximab. Let me take you through the timeline here. In the right eye, we see a worsening picture despite treatment. She also developed some ischemic sequelae in the form of vitreous hemorrhage, which resolved at 32 weeks, revealing a pale disc. Her vision stabilized at 3/60. In the left eye, we see ischemic patches progress and threaten the fovea. We start treatment here and we notice that it stops. So with our timely intervention, not only did we manage to arrest the progression of ischemia, her vision also improved and stabilized at 6/5 uncorrected. At 32 weeks, a patient had received 6 cycles of cyclophosphamide infusion and was on oral anticoagulants and oral mycophenolate mofetil. Let us compare the deep capillary plexus OCTA images of both eyes. The right eye shows a non-perfused macula with distorted vascular architecture, while the well-perfused, healthy retinal vasculature is seen in the left eye. Therefore, while we could not rescue vision in the right eye, timely intervention with interdisciplinary cooperation helped us to maintain the vision in the left eye. Thank you.
Judges, you can ask question and give your comments also.
Yes, Dr. Aastha, very nice, challenging case, and you presented well. I would like to know what was the SLE disease activity index for this patient on systemic evaluation. What was the score on systemic evaluation? So later you revised into SLE, finally it's combined occlusion, dsDNA and ANA was positive.
Yes, ma'am. Yes, it was.
As a beautiful case, very well documented. Your patient was very young, 32, wasn't
20.
it?
21.
21. So one question, I mean, you gave cyclophosphamide.
Yeah.
So what will be one concern which you have to inform the patient before giving cyclophosphamide?
She's a young female, so we do not give cyclophosphamide in case if she decides to get pregnant or happens to get pregnant. It should not be given during pregnancy. So that's something we should make her aware of, particularly because of her demography. Like you mentioned, she's a young
Yeah,
female.
it's not only during pregnancy, it's otherwise also.
Okay.
So great case. Thank you.
Thank you, ma'am.
So suppose
Very-
you wanted to avoid cyclophosphamide, what will be your drug of choice in case of SLE?
Hydroxychloroquine usually be given SLE.
Not your case. Yours is way beyond where
Yeah.
HCQ will work. You want more strong.
Strong.
That's what Dr. Mahendra Das is asking.
Oh, okay. So ideally, even the rheumatologist also had asked for rituximab, but because she couldn't afford rituximab, so that's why cyclophosphamide was given to her.
A very interesting case. I just wanted to understand, what do you think was the pathology? What was happening in the retina, especially for the right eye? Let's stick to the right eye, okay?
Yes, sir.
What was happening in the retina and what was happening in the choroid? And the ischemia that you showed in the opta image in the end. Do you think it corresponded to the perivascular infiltrates that you showed at presentation of the clinical photo?
So it is definitely an occlusive pathology, but maybe the level of occlusion is somewhere beyond. So that's why in the end it was completely distorted. We couldn't see basically the vessels on the OCTA in the end.
Are you familiar with occlusive vasculopathy? It's okay. I mean, you are a resident. I had no clue about these things during residency. I'm just, because you presented such an interesting case, so I'm kind of taking it about. But very nice case. Okay. Thank you.
Thank you, sir. Thank you.
For how long do you think you'll continue the therapy? Last question.
Yes, sir. Yes, ma'am. For how long will we continue the therapy? So anyway, for her, since she's diagnosed with APLA, we will continue her anti-coagulant therapy. But are you asking about the anti-inflammatory therapy,
Yes,
ma'am?
DMARDs.
The DMARDs also, like when the disease activity is not there, we can taper it down slowly.
That's
till
it. Thank you.
Okay, thank you, ma'am. Thank you.
Thank
Just
you.
for the participants, I think we have chosen 3 most friendly judges. So try to interact. If you don't understand the questions, please feel free to ask. And if you have any doubt, this is the platform you can actually ask them. And I can assure you, they are very friendly and will ask any questions or any doubt you have. Yes, Vandana.
Thank you, Dr. Aastha. That was a very interesting case. Our next presenter for the day is Dr. Chavi Mandloi. Dr. Chavi?
Yes, ma'am.
Yeah, you can share your screen.
Am I visible?
Yes, Chavi, it's all good. Go on.
I cannot see the timer actually. Is the timer on?
Yes. Sunilji, timer, please.
I cannot see the timer actually.
Yeah, we'll just start the moment you'll start. Please.
Okay. Good evening, everyone. A 45-year-old male presents to the department with complaints of right eye diminution of vision since 3 days. The patient was already diagnosed with Portner-Skolsman syndrome in 2016 and 17 and was being managed with steroids, anti-glaucoma medications. The fields done at that time in the right eye showed depressed sensitivity points in superior and inferior hemisphere. Although the patient lost to follow-up after that and returned to our clinic in January 2022 with same complaints and visual acuity of 20/60 improving to 20/20. Anterior segment showed 2 fresh white creatic precipitates with a von Herrick grade of 4. Intraocular pressure was 64 millimeters of mercury with GAT and gonioscopy revealed open angles. The right eye also showed a fundus of a cup-cup ratio of 0.7 with an inferior notch. Fields repeated showed depressed sensitivity points in superior and inferior hemisphere, converting into a biarcuate scotoma. Hence, a diagnosis of Portner-Skolsman syndrome was made, and the patient was started on steroids, anti-glaucoma medications, and oral anti-glaucoma tablets. The patient then showed some recovery with resolution of keratotic precipitates, resolution of AC reaction, and a reduced intraocular pressure of 16 from the previous pressure of 64. The patient returned 3 months later with a visual acuity of 20/20. The anterior segment showed granulomatous keratotic precipitates along with coin-shaped lesions and a cell of 1+. Although no iris atrophy could be seen, intraocular pressure was 30 and the fundus examination was as before. Hence, to summarize, a middle-aged Indian male with unilateral recurrent mild acute anterior uveitis with raised intraocular pressure presenting with large white granulomatous keratotic precipitates and coin-shaped corneal deep stromal lesions. Hence, a differential diagnosis would be viral uveitis, CMV, HSV, and VZV related, Portner-Skolsman syndrome, Fuchs heterochromic iridocyclitis, sarcoidosis, secondary glaucoma, or steroid-induced glaucoma. Now, the patient was advised for PCR, but the PCR was not possible. Hence, serology was conducted and HSV and CMV IgG came out to be positive. As CMV IgG was positive and there were characteristic coin-shaped lesions present in the cornea, we started the patient on tablet Valgen cyclovir in a loading dose of 900 mg BID for 2 weeks and a 450 mg BID as a maintenance dose. Now, this is a graphical representation of the trend of the disease, how it has progressed through years. The bottom portion shows us the timeline. Middle portion shows the intraocular pressure through a graph. Also, the anterior segment findings are depicted through the picture, and the topmost portion shows the treatment given at that particular point. As we can see, like in the year 2022, in the 4th month, there was a spike in intraocular pressure of 30 in the right eye. This coincided with presence of keratotic precipitates and coin-shaped lesions. At that time, we started the patient on anti-glaucoma medications, steroids, and antiviral. In this graph, we can particularly see that along with every raised intraocular pressure bout, there has been an anterior segment inflammation coinciding with that. We continued the patient on anti-glaucoma medication, steroids, and antiviral throughout the course of this disease, but the bouts kept on happening and the anterior segment findings like cone-shaped lesions and keratotic precipitates were seen. The patient also lost to follow-up for some time in 2023, although after that, he returned with a shoot of IOP as 42. That at that time, we advised the patient for a trabeculectomy, after which the intraocular pressure reduced for some time, but again, it reoccurred as the anterior uveitis bouts kept on happening. In 2024 January, we shifted the patient from valganciclovir oral to a topical ganciclovir 0.15% ointment, as studies have showed some similar recovery in patients on topical tablets as well. Hence, the patient was managed similarly for some more time. Currently, the patient came in December with a visual acuity of 20/20 and an intraocular pressure of 26, developed a PSC, fundus showed near total cupping. Currently, the patient is on maximum glaucoma treatment and also on a steroid tapering dose along with antivirals. Thank you.
Thank you, Dr. Chavi. I invite our judges for their questions and comments on the case.
Dr. Chavi, it's a great case. What the practical challenges we face in a clinic? So name that diagnostic test to diagnose your CMV anterior uveitis.
The gold standard test would be a PCR, an aqueous PCR, as it would directly measure the viral load and has a higher sensitivity and specificity. So it would be quite highly diagnostic.
Any other imaging modalities can help you?
Specular, we could do for endothelial testing.
Any other methods with the characteristic description for CMV anterior uveitis? Clinically, you showed us the nice coin-shaped keratic precipitates. Any classical appearance have been described with confocal microscopy in a case of a CMV anterior uveitis?
Cells with prominent nuclei with
Owl-shaped inclusion bodies.
inclusion bodies, yes.
Great case. Chavi, I was kind of a bit surprised. Why did you not start the topical treatment early, topical ganciclovir, Whitstone gel? Because it was after almost 2-3 years you introduced that, and then you weaned off the patient off the topical very fast. So what was any particular reason why systemic as first line of therapy?
Initially, the systemic medications showed some response with respect to the anterior uveitis, although we could not control them very properly. Along the years, eventually, we decided to shift on the topical medication because of the studies which we had read. Although the ganciclovir also did not prove to be of much benefit, and hence we stopped it quite fast and again shifted the patient on systemic, because in other patients as well, we had seen a quite good recovery with systemic medications.
Any topical formulation you'd like to recommend?
Yeah, and the topical medications also does not reach the aqueous levels quite high as a systemic would. So we continued with the systemic medication.
So in addition to the topical Virsan gel, any other topical formulation is more effective, or is it available? You can make topical eye drops 2%, then give.
So my question, sorry.
Just one more question. If you were to treat this patient again, would you change anything the way you managed?
Already managed, or now what would we like to do?
I mean, suppose you see a similar patient. Is there any learning outcome from your patient so that you will treat your next patient bit differently?
After the initial systemic treatment, if the patient shows increase in IOP furthermore, we would not wait for such a long time to intervene for trabeculectomy. Maybe we would do it earlier, as the inflammation is quite chronic, but we could stop the glaucomatous process if we intervene early as much as we can.
That's very important, because CMV generally have uncontrollable glaucoma, which usually sometimes can be very difficult to control with medical management alone. So surgical intervention could come much earlier. Okay, Soumya, go ahead.
Yeah. So my question is, suppose you test 100 people in the Indian population for CMV, IgG and IgM, how many do you think will come out with a positive test? You showed a positive IgG, right? So
80 to 85%.
yeah, so I mean, I knew 90%, but you're close enough. So how do you think your testing of IgG, because you said now that we had seen a clinical picture and we also got a serology. So do you think you will base your treatment when PCR is not available? You will start your treatment based on the serology, or how will you go about?
Like in our case, we would have loved to go for a PCR, but as it was not possible, we would, IgG CMV is has high seropositivity. A lot of patients would be positive without the presence of CMV and uveitis, but coin-shaped lesions are quite characteristic.
That's
So
true, but the IgG, can it help you in any way? Not just for CMV, let's say for toxoplasma. Your IgG values, can they help you? We all talk about IgM, right? IgM coming positive means acute infection, etc. So how can the IgG value help you in this case or in toxoplasma? How can
it
the
could
IgG?
it could point at a previous infection.
Think of it the other way around. Suppose you have a negative IgG for either CMV or toxo. At least you are sure that this is very unlikely to be that infection. So it will help you in ruling out the infection, definitely not in ruling in the infection. I told this because we do this all the time. Okay. And one last question. Any anti-glaucoma medication that could be avoided? I think you have used this in this patient. Any anti-glaucoma medication that could be avoided in a viral anti-uveitis, especially CMV?
Dorzox
Why?
and latanoprost.
Why?
It can Dorzox could lead to latanoprost could lead to increased inflammation,
Okay.
trabecular inflammation, and yes.
Okay. All right. Thank you very much.
I would love to take this opportunity to ask all the experts, like in this particular case, as we have tried to manage it with maximum glaucoma intervention and surgery as well, but still the patient has not got into a remission. He is still in follow-up, he still comes to us. So what would be the next step of action? As a glaucoma drainage device could be one, but we would love to know what should be done in next step.
So the first thing in these patients is that you have to understand the inflammation is not going to go away in the next few years, So that is number one. Uh, for me, whenever I suspect CMV, I always do confocal, specular, and PCR. If it is positive and your clinical phenotype is suggestive, topicals are given in my practice. That's the first line of treatment. And systemic becomes the second line of treatment, not vice versa. So, steroids, topical steroids, anti-glaucoma, of course, and ganciclovir gel, preferably 3%, 2 to 3%, 1.5 generally has a less efficacy, as you said. That given majority of the times the inflammation actually clears very soon and you will see capes disappearing. Uh, Anti-glaucoma comes down. But the important thing is you do not taper it off. You keep that medication, like if my patient is controlled on topicals alone, I will keep topical for a very long time, very slow tapering, making it 3 times for 2, 3 months, making it twice for 2, 3 months, so that the disease does not come back. And the glaucoma filtration surgery, which is always a tube, will be done much early in the course if required. If the disease is coming back and you decide to add systemic therapy, which typically is Valgan, you begin with 900 milligram BD for the first 12 weeks, but then you don't stop it. You make it 900 OD for next 6 months, 8 months, 450 milligrams. So it's almost for 2 years or so you maintain that sweet spot so that the inflammation does not keep coming back. Every time you taper off the medicine and inflammation comes, it results in the residual damage to trabecular meshwork. So that's the way to go.
Thank you, ma'am. Thank you, everyone.
Padma ma'am, do you have anything to share?
It's early detections and appropriate optimum antiviral therapy plays a role. We can bring down. If it's resistant, already structural damage is there, we'll go for the surgical intervention. Like more importantly, we have to counsel the patient for the chronicity and long-term maintenance, like Dr. Vishali ma'am said. And these patients, they come back with recurrences, but whenever we have to warn them with the signs, when they come back, we have to start the treatment.
Samya, sir?
Nothing else. Thank you.
Nothing. Okay. Thank you, sir. Thank you, Dr. Chavi, and thank you, judges, for that. For those insights, valuable insights. Next, may I invite Dr. Dharti Punjabi? She'll be presenting our next case. Dr. Dharti, you may please share your screen and you can start presenting.
Good evening. Is my presentation visible?
Yes, yes. Go ahead.
Am I audible?
Yes, you are.
Good evening, respected judges and my fellow doctors. Myself, Dr. Dharti Punjabi. Today, I will be presenting a rare case of idiopathic frosted branch meningitis in aseptic meningitis. A 40-year-old lady presented to emergency room with complaint of headache and vomiting. She was diagnosed with aseptic meningitis after series of investigations and was started on IV ceftriaxone and was discharged after improvement of symptoms. Following investigations were done, CT brain showed leptomeningeal enhancement, while CSF examination revealed lymphocytic predominance with elevated protein, along with raised ESR and CRP. Rest of the investigations were negative. 10 days after the discharge, she came with complaint of blurring of vision in both eyes associated with headache. There was no relevant systemic history. However, she had undergone both eyes cataract surgery elsewhere, and on contacting the surgeon, she was found to have Fuchs uveitis related cataract. She had no history of steroid intake. She consumes vegetarian diet and has no addictions. There was no relevant family history, and her general physical examination was within normal limit at presentation. On ophthalmic evaluation, her best corrected visual acuity in right eye was counting finger 3 meters and in left eye was counting finger 2 meters. Lids, adnexa, and rest of the anterior segment was within normal limit. Both eyes were pseudophakic and her intraocular pressure was 20 millimeters of mercury with Goldman applanation tonometry in either eye. Extraocular movements were full free and painless in both eyes. Both eyes dilated fundus examination revealed disc edema with grade 2 vitritis, extensive perivascular cuffing with hemorrhages, and retinal opacification involving macula suggestive of ischemia. Both eyes OCT was done, which showed hyperreflective dots at vitreomacular interface suggestive of vitritis. There was hyperreflectivity of inner retinal layers with loss of foveal contour suggestive of ischemia. There was hyporeflective area between outer retinal layer and RPE suggestive of subretinal fluid, which was more in left eye as compared to right eye. Following workup was done, CSF PCR for IgG and IgM, VZV, whole blood PCR for HSV, serum TPHA, aqueous PCR for HSV1, 2, VZV and CMV, autoimmune workup including ANCA panel, ANA panel, and rheumatoid factor, CT chest, and peripheral blood smear, which all came out to be negative. So our impression was idiopathic frosted branch meningitis. She was treated with 1 gram of IV methylprednisolone for 5 days along with oral Velgen cyclovir till the reports came. Topically, eye drops prednisolone acetate 1% 3 hourly and home atropine 2% BD. After 5 days of IV MP, she was switched to tapering dose of oral and topical steroids and was also started on tablet azathioprine 50 mg once a day along with oral steroids. And the dose was escalated to 100 mg after LFT and RFT was normal. On day 4, her vision in right eye was counting finger 3 meters and left eye was counting finger 2 meters with corresponding fundus picture. Day 7, her vision in right eye was counting finger 3 meters and left eye was 660. Day 18, her vision in either eye was counting finger 3 meters with star-shaped macular exudates. At 1.5 months, her vision improved to 660 with pinhole in right eye and 624 in left eye with gradual reduction in disease activity. OCT at 1.5 months showed resolution of subretinal fluid with restoration of foveal contour. At 2.5 months, her vision in right eye was 636 and 624 in left eye. At 6 months, her vision was 69 and 8 in right eye and 69 and 6 in left eye with significant improvement in the clinical picture. At 8 months, her vision was stable with 69 and 8 in right eye and 69 and 6 in left eye with complete resolution of frosted branch meningitis. At 8 months, OCT was done which showed normal foveal contour with no evidence of subretinal fluid. FFE was done at 8 months to look for CNP areas which showed normal fluorescence with no evidence of capillary non-perfusion areas. Thank you.
Thank you, Dr. Dharti. May I please invite the judges for their questions?
Dharti, it's a beautiful case and you managed it well. The outcome is very good. Coming to frosted branch meningitis, you have looked it for viral, you have checked it, most of the AC tab for the PCR. And what are the other diseases can cause frosted branch meningitis apart from the described viruses, whatever you look for?
So apart from the described viruses, frosted branch meningitis have been reported in cases of systemic lupus erythematosus. So we did ANA panel for the same. It has also been reported in few cases of juvenile idiopathic arthritis and also
What are the other infections can cause?
so other infections that can cause are toxoplasmosis and then
Did you look for toxo in your case?
yes ma'am, we did CSF IgG IgM for toxo. Syphilis can lead, there are cases of syphilis which can show frosted branch meningitis.
How was the aseptic meningitis symptoms? How long does it take to resolve?
So her symptoms resolved within 10 days of treatment. She was started on IV ceftriaxone and it started resolving within few days and she was completely clinically asymptomatic after 10 days and was deemed fit to discharge.
So since you're given empirical ceftriaxone, do you think infection must have triggered this episode?
Infection must have triggered, but actually before starting the ceftriaxone, we had sent all our investigations before the empirical treatment was started and they all came out to be negative. So there is a very less chance of the infective etiology in our case.
Over to other judges.
Yes, Dharti, how would you define aseptic meningitis?
So ma'am, aseptic meningitis is a condition where none of the probable causes of the disease come out to be positive. So all the infective probable causes that can lead to meningitis
Are ruled
were
out.
negative, yes, are ruled out.
So how should you treat aseptic meningitis?
So as cephalosporin is a broad spectrum antibiotic,
No, but you ruled out all the infection and that's why you defined it, you labeled it as aseptic. So
yes.
if we label it as aseptic, why should we give antibiotics? So probably we are not sure.
Yes.
You know, my second question to you is, in a scenario like this where patient has had meningitis and frosted branch meningitis, what would be the differential, the entities which can affect both which can cause both meningitis and frosted branch.
Meningitis along with frosted branch meningitis. So, syphilis, in neurosyphilis, there is raised intracranial pressure leading to meningitis, and there can also be presentation of frosted branch meningitis.
Syphilis, what else?
Then,
So your patient had increased lymphocytes on CSF. So what are the conditions can cause increased lymphocyte counts?
tuberculosis can lead to increased lymphocyte count.
And somewhere I heard you also gave Valgan. You said you gave steroids and Valgan and then you stopped.
So, because CMV retinitis is the closest differential which we thought of, so we started oral Velgan cyclovir till the reports came out to be negative.
Which reports?
So we had sent for aqueous. Aqueous sample
PCR.
was sent for viral PCR, which
And
included
what is the positivity of viral PCR from aqueous?
positivity. You mean sensitivity and specificity?
Yeah.
So 96 to 98% specificity is there.
And sensitivity?
Approximately 95%.
I wish.
Which is more, vitreous or aqueous?
Vitreous.
So you were lucky, your patient responded well. But one thing again, besides SLE would be another thing, which can be both. Behçet's is another thing. There are quite a few diseases which can affect. Sarcoid is another one which will respond. So you will have to rule them out. So Dr. Padma Malini was asking you questions. So these are some of the diseases which you will have to keep in mind. You were lucky. The patient probably was non-infectious and responded very well, but you have to be very cautious and many a time repeat the investigations if things are not going in the right direction. That said, I will repeat the angiogram, though the vision seems 6-6, everything seems fine, and wide field especially if available, because many a times you will have the capillary non-perfusion which will be silently progressing and you may get surprise of hemorrhage one day. So that point needs to be looked into.
Yes, ma'am.
Soumya.
Yes, my question is related to the last point you raised about the fluorescein angiogram. So you mentioned while describing the OCT at presentation that there was inner retinal hyperreflectivity which could be due to ischemia. We know that ischemia causes that. But the FFA which you showed at 8 months when the disease had resolved didn't have any evidence. Of course, it was not wide field, but the OCT that you showed was from the macula, right?
Yes.
So that was showing inner retinal hyperreflectivity. So now, if you think of the FFA that you got in the end, do you think that the hyperreflectivity could only be due to ischemia, or it could be a different reason as well?
It can be due to not only due to ischemia and something else.
I think I would like to learn, Dr. Vishali, your thoughts on this.
Soumya, that hyperreflectivity, what she was showing initially, and that retinal fluid, I thought, oh, it looks like viral because there were cells on top of that retinal hyperreflectivity. You do see hyperreflectivity in ischemic lesions, but they should not have cells. Now, this hyperreflectivity with cells would bother me personally, and I would put CMV very high. Negative PCR honestly doesn't bother me. If it looks like CMV, I would pay a lot of attention to that. And personally, I would not have tapered Valgan just after PCR report. I would have completed the course because these patients do respond. And then you realize the arterial closure. I will also uh, put very close attention to what is happening to the arteries, because CMV causes arterial occlusion, which slowly keeps on getting progressive. So I would pay attention to that.
Yeah. But I mean, looking back, you think that the OCT hyperreflectivity was probably not ischemia, right? I mean,
It could be combination because
combination.
it responded very well to steroids and immunosuppression.
Right. You have any questions for us, Dr. Dharti?
No, sir.
Thank you.
Thank you.
Thank you, Dr. Dharti, and thank you, judges.
You are Dharti or Dharti?
I'm Dharti, ma'am.
Dharti.
Yes.
Okay.
I thought so.
So thank you, Dr. Dharti, and thank you, judges. Moving on to the next case presenter, we have Dr. Harita TM. Dr. Harita, you may please share your screen.
Shall I start now? Good
You may
evening,
begin.
everyone. I am Dr. Harita, presenting the case title When the Eye Spoke First, Ocular Clue to Systemic Vasculitis. We have a 30-year-old female patient referred by the ENT surgeon for ophthalmic evaluation. She presented with complaints of bilateral eyelid swelling, redness, and watering since 5 days. Also with inability to close both eyes since 5 days, diminution of vision in the left eye since 3 days. In the past history, she was having bilateral hearing loss and discharge from both ears since 2 months. It was associated with rhinorrhea and occipital headache. She also noticed drooping of the corner of the mouth on the lateral side 1.5 months back and bilateral drooping of the eyelid since 2 weeks. She was diagnosed as bilateral chronic automastoiditis with grade 3 element facial palsy elsewhere. She received IV antibiotics and systemic antifungals. Endoscopic nasal mucosal biopsy and lacrimal gland biopsy was performed by the ENT surgeon. The direct immunofluorescence biopsy of the tissue showed negative On general examination, the patient was conscious oriented but appeared lethargic and fatigued. She was moderately built and nourished, no significant lymphadenopathy noted. On ocular examination, the vision is right eye 6/18 with nil improvement with pinhole, left eye 6/36, nil improvement. There was bilateral S-shaped ptosis. Mild lag of thalmos was there in the right eye. Left eye showed significant lag of thalmos. Lacrimal gland enlargement was there bilaterally with mild tenderness. Conjunctiva was congested, severe chemosis, and query scleritis. The cornea, bilaterally, there was peripheral ulcerative keratitis with exposure keratopathy. In the left eye, also with epithelial breakdown at 6 and 8 o'clock position. The corneal sensation was reduced in both eyes. Ocular motility, there was restriction in the lateral gaze. Proptosis was mild. Anterior chamber was quiet. Pupils was normal. Posterior segment examination was normal. This is the slit lamp image where we can see bilateral. There was enlarged lacrimal gland and there was a peripheral ulcerative keratitis and there was also the fluorescein staining. The B-scan, we can see the enlarged lacrimal gland supratemporally. We proceeded with the nasal endoscopy, which revealed a nasal septal perforation with the necrotic tissues. MRI brain and HRCT temporal bone was done, which showed ill-defined nodular soft tissue lesion in the left nasal cavity, chronic bilateral automastoiditis, bilateral lacrimal gland enlargement, no evidence of intracranial mass lesion. Provisional diagnosis with recent onset, rapid progression of symptoms having bilateral bacteroadenitis, bilateral automastoiditis with paranasal sinusitis and cranial nerve palsy, along with scleritis and bilateral peripheral ulcerative keratitis, most probably suggestive of systemic vasculitis, that is granulomatosis with polyangiitis, infectious etiology, IgG4-related diseases, and sarcoidosis. We proceeded with the blood test. Complete blood count shown leukocytosis, neutrophilia, relative lymphopenia, mild anemia, and RBC count was borderline low. Platelet was thrombocytosis, and CRP was elevated. Renal function test and serum electrolytes was normal. Serology was non-reactive. protein and immunoglobulin profile. The serum protein electrophoresis, hypoalbuminemia with increased alpha-1 and alpha-2 globulins, and serum IgG4 was mild elevated. Autoimmune workup showed anti-PRT-ANCA, which was strongly positive, anti-MBO-ANCA negative, ANA-NRNP bar SM was positive, ANA histone was 2+, serum ACE was 41. Audiometry was done, which showed bilateral conductive hearing loss. Pathological report showed the granulomatous inflammation with vasculitis. Acid fast bacilli and fungus stain was negative. The treatment was initiated in both eyes, started on antibiotic and steroid eye drops and antibiotic eye ointment. Lubricants and eye patching was done at night. Treatment, systemic treatment, intravenous methylprednisolone 1 gram per day, pulse doses into 3 days, followed by oral corticosteroids in tapering dose. Intravenous rituximab infusion 1 gram, which was repeated after 2 weeks. This is a follow-up after 1 month. Peripheral corneal infiltrate, regressing and scarring. Facial weakness and ptosis was improving. So she was symptomatically better. Hearing status quo. This is the outcome after 1 month with best corrected visual acuity 6/9 in both eyes. Thank you.
Thank you,
This
Dr.
was
Harita.
a,
Over
yeah,
to the
this
judges,
was an
yes, sir.
excellent case. Yeah, very well documented, and I think great learning for understanding ANCA vasculitis. So my question is, not directly related to the ocular findings that you had. Since you mentioned this as systemic vasculitis, right? So what do you think is the prevalence of retinal vasculitis in patients with systemic vasculitis? Should we investigate for ANCA in patients with retinal vasculitis?
The prevalence is comparatively lesser. First, we need to give the routine investigations. When we are suspecting any clue or suggesting anything, we can proceed with the further.
Yeah.
And
you should look up a study. I mean, I was not expecting the answer for you either, but it's important for us to be aware. That's why I asked you this question. So, if you look up a study by Professor Jim Rosenbaum, who is both an ophthalmologist and a rheumatologist, his study shows that out of 1,000+ patients of uveitis and I think 400 or 500 patients of retinal vasculitis, only 1.4% of those patients, and that's a TB non-endemic country, so they mainly have non-infectious causes of retinal vasculitis. Even amongst them, only 1.4% had any evidence of systemic vasculitis. So the likelihood that your retinal vasculitis patient has this thing is very, very less. But wonderful documentation. I hope a lot of people are watching this. This is great learning. Thank you.
Thank you, sir.
Very nice.
Thank you.
Harita, your case is an excellent case where it shows the eye acts as a window to the systemic disease, and also your patients had other systemic manifestations as well.
Yes.
In the histopathology biopsy, which site it was done?
Ma'am, we have done in Center for Sight, actually. We have
No,
sent
I'm asking from the site of the biopsy site from the body.
Ma'am, it was done from the lacrimal gland. ENT surgeon has performed, ma'am.
Sure. So in the order of presentation, first you showed us the biopsy report, then you showed us the radiological imaging, then you showed the serological. So when we go, we do the clinical evaluation, systemic evaluation, imaging, and then we go for the biopsy, the order of presentation.
Yes, ma'am. I have presented because when the patient presented to us, she has already gone and visited that is why we have presented. Which was available to us, I presented first.
It's good. And one more thing, what are the other organs can get affected? You showed us the lacrimal gland swelling, and you showed the mastoid region, and classically the nasal septum collapse. And whenever we see the scleritis with the marginal corneal infiltrate, we need to rule out the autoimmune. That is a classical description. What other organ you will look for in this particular condition?
Ma'am, one organ is renal. Glomerulonephritis can be affected. The second is lung. Where we can see the nodules and infiltrates and cavities in imaging. Other all vasculitis can be affected in your organs. Cranial nerve can be affected.
So yeah, we have to look for involvement of the renal and the lungs. Many times they may meet with other infective causes.
Yes.
Thank you,
Pardon?
Doctor.
I have one more question.
Yes, sir.
Suppose, you have all these systemic findings, right, which are telling you that there is likely to be a ANCA-associated vasculitis,
Yes.
but you get a positive Montu test in this patient. Okay, how will you interpret that Montu test in this case?
Still, the infective etiology of TB we can suspect, sir. But since we are in India with Mondu is not that reliable, can be positive in all. We can keep in mind as a DD.
No,
Sure.
there is a different answer to this. I mean, that's a regular answer. There is a slightly more academic answer to the question. Okay. So our secretary of the UVIEITS Society has published this study, right?
If we are suspecting TB, we can give the
No.
Many times it get confused, but
yeah.
Yes.
So the Montu test, or for that matter, even the IGRA test, they can cross-react with ANCA antigens, okay? Anti-neutrophilic cytoplasmic antigens, okay? They can cross-react both C-ANCA and P-ANCA. And that is how you can get a positive test in either case. In a TB patient, you can get a positive ANCA, and in a ANCA patient, you can get a positive TB test. So you have to be cautious while interpreting these tests, and you had such excellent systemic findings to fall back on.
Yes.
Thank you.
Even ANA would have cross-reactivity. So there also you'll have to be careful.
Yes.
Thank you.
Thank you. Thanks.
Thank you, Dr. Harita, for that wonderful case presentation. Next, we have our next candidate, Dr. Irene Rosejoy. Dr. Irene, you may start.
Ma'am, a very warm good evening to all. Demystifying the silent crime. This is a 28-year-old male who presented with the left eye defective vision, redness, and pain of 3 days duration. He has a history of exposure to pulmonary tuberculosis from his father. On examination, his right eye was normal. Left eye, his vision was 6/36 with no improvement in pinhole. Anterior segment examination showed subconjunctival hemorrhage, circumcorneal congestion, and cells of 2+ grading. Right eye fundus was normal. Left eye, media was hazy due to mild vitritis and dispersed vitreous hemorrhage. There was extensive periphlebitis, clinically resembling frosted branch uveitis, along with perivascular sheathing in the inferior quadrant. There was multiple superficial intraretinal and subhyaloid hemorrhage, indicating the presence of hemorrhages in all layers of retina, along with macular edema. We went ahead with OCT, and OCT through macula showed hyperreflective dots in the posterior vitreous space due to vitritis or vitreum. Inner retinal hyperreflectivity due to retinal ischemia, inner retinal edema, and subretinal fluid. The yellow arrowhead depicts sub-ILM hemorrhage. This shows subhyaloid hemorrhage with backshadowing. So from our clinical examination, we came to a probable diagnosis of left eye panuveitis with occlusive vasculitis. Our differential was intraocular tuberculosis and probably a viral etiology. Thus, we initiated the patient on oral valacyclovir 1 gram TDS, topical steroids, and antibiotic. Meanwhile, we went ahead with blood investigation. The uveitic workup came out to be negative, except for Mantoux and IGRA, which was positive. CBC was within normal limits, except for high normal eosinophil counts. Autoimmune workup, AC tab for MTB and viral markers also came out to be negative. So in endemic country, with a young male with a history of exposure to pulmonary TB and fundus picture showing occlusive vasculitis with the Mantoux and IGRA IGRA being positive, we presumed this to be a possible intraocular tuberculosis. Thus, we initiated the patient on ATT and oral steroids. The patient improved a lot. In 1 month follow-up, patient's vision improved from 636 to 612 and in pinhole to 69. There was resolving hemorrhages and vasculitis. OCT showed resolved edema with normal foveal contour. There was also reduction in the subialum pocket of hemorrhage. There came the twist to our story. At 6 weeks, patient presented with photophobia and examination showed a small bump in the inferior part of the iris. To confirm, we went ahead with gonioscopy examination. And to our surprise, there was a whitish cylindrical elongated worm with tapering ends in the inferior angle. Our next action plan was emergency surgical removal of the worm. This is the edited video. The side port was entered using kerato. Pilocarpine was injected. AC was formed with viscoelastic. And the worm was removed in toto using microforceps. Histopathology examination showed advanced third stage of nematode gnathostoma spongerium. ATT was stopped, steroid was continued, and 1 month oral albendazole was initiated. At 4 months, his vision was 6 parts. There was resolving hemorrhages and sclerosed vessel, and OCT showed disorganization of inner retinal layer with resolution of all other findings. And yes, finally, the silent crawl was demystified. It was a case of left eye uveitis with occlusive vasculitis secondary to ocular gnathostomiasis, which mimicked like an intraocular tuberculosis. So our take-home messages: in cases of uveitis with retinal vasculitis and retinal hemorrhages in all layers of retina, especially when the uveitic workup is inconclusive and there is peripheral eosinophilia as in our case and elevated serum IgE, ocular parasitosis should be considered. Such patients require close and repeated follow-up to identifying the migrating intraocular larva. With this, I end my presentation. My sincere thanks to the respected judges, Dr. Pathu sir, and the organizing committee for this valuable opportunity. Thank you.
Thank you, Dr. Irene. That was a really exciting
Thank you.
case. Over to the judges.
Thank you.
Irene, it was a great case.
Yes,
When you
thank
see
you.
for the first time, did you see any changes on the iris on slit lamp
No, ma'am.
examination? No holes,
Yes,
no
ma'am.
atrophic patch.
Usually iris holes will be seen when the worm penetrate from the posterior to anterior chamber. But in our case, there was no evidence of any worm penetration in the iris, ma'am. There was no any iris holes was not there.
So when you remove the worm, it was alive or a dead worm sitting?
Ma'am, it was a dead worm, ma'am, when we removed from OT.
Yeah, that can explain your
days.
occlusive vasculitis and immunological reaction.
Yes, probably, yes.
Beautiful
So
case.
Thank you.
Soumya?
Yeah, I was just wondering, do you think there could have been two different pathologies existing at the same time? Did you give that a thought?
Yes, sir, probably, sir. So, patient was on ATT, and though we stopped ATT, patient improved a lot, and we had his follow-up 5 days back. Also, patient visited a hospital. He was doing well, and his vision was 6/6. So we believe that the primary cause will be only the intraocular gnathostomiasis, though they can.
The
Yeah.
response could be due to steroids, you feel?
Yes, sir. Yes, ma'am. Initial response would have been due to steroid, but after post removal of the worm, it's been almost 6 months. Our patient didn't had any recurrence or there was no symptoms per se.
So, I mean, of course, you have the worm,
so
the proof is in the pudding. So you have the worm sitting in front of you, and it's hard to say another pathology when you have that. But if you look at the kind of, pathology you had in the retina, that kind of a confluent
Yes.
retinal vasculitis restricted to one sector.
Yes.
It was not,
Sector.
it was not diffuse,
Yes, sir.
right?
So
Yes,
with
yes,
that
yes.
kind of a picture, which is very different from, we just heard a case of frosted branchitis with meningitis, okay, which was quite
Yes,
different
yes,
from what we saw in this patient. So, I am not
yes.
very convinced. Of course, there's nothing to prove, but I'm not very convinced that it was the worm that was causing the vasculitis. Okay,
Okay,
so
yeah, okay, sir.
even if we assume that the worm was
Yes,
causing the vasculitis, I think if we have started the anti-TB therapy, it is always good to complete the course, because if we give
okay,
incomplete course, there's a very high risk of drug resistance developing in the patient. Suppose the patient has
okay,
some bacteria in the body unrelated to the eye disease, okay,
okay,
they would end up
yeah,
with drug
okay, yes, sir.
resistance. So it would have been good,
Okay,
even
yeah,
if we assume that this was a worm causing the vasculitis, would have been good to complete the course of ATT in this patient.
okay, sure.
I think if you do ICG, now in your case, the worm actually came much later. But whenever
Yeah,
in
yeah, ma'am,
doubt, I
6 week,
think,
ma'am.
yeah, looking at the ICG and the pattern of choroidal involvement may give you an idea differentiating whether they were two diseases or the worm cause, because TB choroidal involvement is very typical. My question to you,
Yeah,
why did
yes.
you give antibiotics while waiting for the results? You said you gave systemic
Yes.
antibiotics. Why?
Or, no, ma'am, we started with topical steroids and antibiotic and oral valacyclovir only, ma'am. Oral antiviral. Oral antibiotic we didn't mention.
Okay. Thank you.
Thank you, Dr. Irene. Next, our next
Thank you,
candidate.
thank you.
We have our next candidate, Dr. Manisha.
Can I start my presentation?
Yes, you may begin.
Okay. Good evening, everybody. Today I'm presenting a case of a 24-year-old male who presented to our OPD with diminution of vision in both the eyes in 6 months. There was history of night blindness since childhood. There was no history of any redness, pain, or any systemic ailment. There was no history of any TB contact, any joint pain, orogenital ulcer, or trauma. But there was history of consanguineous marriage that was present. Coming to the anterior segment evaluation, in the right eye, the visual acuity was 6 by 24 parts and IOP was 17 mm of Hg. Under diffuse illumination, under slit lamp, the anterior segment was normal, AC was quiet. In the left eye, the visual acuity was 2 by 60 and intraocular pressure was 15 mm of Hg. And under slit lamp examination, there was broad-based posterior synechiae from 7 o'clock to 11 o'clock with iris pigments on the anterior lens capsule. Coming to the posterior segment, in both the eyes in the anterior vitreous phase, there were minimal cells. There were arteriolar attenuation with peripheral sclerosed vessels. There was a whitish, yellowish, deep retinal lesion suggestive of lipoid-like deposits. And there was pigmentary mottling all around the fundus. On fundus autofluorescent in both the eyes, there was the area of central hyper-autofluorescence and circumferential hypo-autofluorescence surrounding the disc and the temporal arcades. Coming to the OCT, this is the radial scan in the right eye. There was normal foveal contour with the epiretinal membrane. There were extrafoveal cystoid spaces in the outer nuclear layer. There was disruption of outer retinal layers temporally seen. There is this RP elevation in the area that is corresponding to the deep retinal lesion seen in the fundus photo. In the left eye, this is the radial scan passing through the optic disc. There is thickened posterior hyaloid phase seen, and there are interretinal cystic spaces. And similar to the right eye, there were these RP elevation corresponding to those deep retinal lesions with hyporeflective spaces in the choroid with loss of choriocapillaries and settler layers, what we termed it as choroidal caverns. Then on fundus fluorescein angiography, in both the eyes in the early phase, there was this patchy filling defects of the choriocapillaries that were corresponding to the areas of the lipoid deposit. And in the late phase, seen in the yellow arrow, there is staining of the lipid deposits. And as shown in the green arrows, there is this stippled hyperfluorescent areas which were corresponding to the area of the capillary loss. Coming to ICGA, in both the eyes, there was this hypocyanosin seen in the areas of lipoid deposits. So we made a provisional diagnosis of a atypical retinitis pigmentosa or pan-uveitis of unknown origin. ERG was performed and there was diminished A and B wave in both the scotopic and the photopic responses. We ordered a battery of tests which all came unremarkable, but keeping in mind the bilateral symmetrical presentation, we went ahead with whole exome sequencing in which there was lysine to asparagine substitution at codon 250 in the CAPN5 gene. So we made the final diagnosis of both high autosomal dominant neovascular inflammatory vitreoretinopathy stage 2. This is the picture at 6-month follow-up. And in the left eye, the patient was PL denied. There was under diffuse illumination, we could see there is circumcorneal congestion. There was neovascularization of the iris. There was ectropion UVA. And in the B scan, there was total retinal detachment. But in the right eye, the patient has a normal anterior segment maintaining a visual acuity of 6/18. But after a multi-pronged treatment approach, patient was given multiple intravitreal anti-VEGFs, oral steroids, and methotrexate. Thank you.
Thank you, Dr. Manisha. Over to the judges.
Very complex case, and thanks for presenting. I think the consanguineous marriage that you showed was unrelated to the patient, right? I mean, yeah.
So that was unrelated to the patient.
But any other differential, like non-inflammatory differential that you would have considered for this patient? We know that RP is there. I mean, there is no
RP
doubt
is
about
there.
retina.
So there was one differential that was CRB1 associated codes like vasculopathy, but on performing the genome sequencing, it was in the CAPN5 mutation. So that was ADNIV. That's how diagnosis was made. But fundus picture was the first differential was CRB1 associated vasculopathy because that's also seen in RP.
Yeah.
So that was the case.
I have a feeling, I mean, are you from Chitrakoot?
Yes.
Yeah, I think I was involved in the diagnosis. But now when I look at the future course of the disease, so I have a feeling your left eye might have had some kind of uveitis on top of Edwin, because both your eyes were very symmetrical in retina.
Yes, ma'am.
Bilateral symmetry is something which will lead you to the diagnosis of
Yes, ma'am.
dystrophies
Yes, ma'am. Yes, ma'am.
rather than inflammation.
Yes, ma'am.
That said, the kind of the synecdoche you showed in the left eye, that is not something you would expect in a patient with retinal dystrophy.
Yes, ma'am.
And that developing into ectropion UV, into later on detachment, I was not aware of this part of this. I think there was a component of inflammation in the left eye on top of the dystrophy which the patient had. And probably when we are seeing the inflammation, which is out of proportion to what you would expect from a dystrophy,
Yes, ma'am.
maybe it's still important to treat that inflammation with immunosuppression, corticosteroids, or whatever, and so that we don't suffer from the sequelae of inflammation. Because normally we all say, oh, dystrophies have inflammation, but that's a very mild kind of cells hanging in there, So your patient probably had something going in the left eye.
Yes, ma'am.
Great case, Manisha. I also go with the same view as ma'am. Whatever the heartbeat we have seen, we have treated with immunosuppression or this they responded, but this left eye had an aggressive course and developed a complication. We need to look for the other cause as well.
Yes, ma'am.
Thank you, Dr. Manisha. Thank you, judges. And with that, we have come halfway through our event today. And next, we have Dr. Nikita Kala with her presentation. Dr. Nikita, you may please share your screen and begin presenting.
Yes, sir. Good evening, esteemed faculty. I shall be presenting a case titled Fog Lights On. So, a 21-year-old man presented to the OPD with chief complaint of sudden onset, painless diminution of vision in the right eye since 2 days. This was the first such episode. He had no previous significant ophthalmic history and no systemic history. On examination, the uncorrected visual acuity in the right eye was 6/48, not improving further. Near vision was N36 and intraocular pressure measured with Goldman applanation tonometry came to be 14 millimeters of mercury. The left eye was normal. On anterior segment evaluation using the slit lamp biomicroscope, there was mild ciliary congestion. Fresh fine keratic precipitates were seen on the endothelium. There were cells of grade 2 plus in the anterior chamber, and there was an RAPD of grade 1 in the right eye. The left eye was unremarkable. On fundus examination of the right eye using a plus 90 diopter lens on slit lamp and indirect ophthalmoscope, the media was hazy. There was a fluffy white lesion, 1 disc diameter in size, just superior to the optic disc, obscuring the superotemporal arterial arcade. The disc margins were blurred and the retinal vessels were tortuous. The left eye was within normal limits. The right eye optical coherence tomography showed hyperreflective dots in the vitreous cavity, posterior vitreous cavity, suggestive of vitritis, a thickened posterior hyaloid, hyperreflective full thickness retinal involvement with shadowing of the underlying choroid, intraretinal and subretinal cystic spaces suggestive of fluid accumulation. So in summary, this is a young presumably immunocompetent patient with unilateral focal retinitis involving the posterior pole along with associated vitritis. Viral retinitis was considered, but the absence of peripheral involvement made it less likely, and cytomegalovirus was unlikely given the immunocompetent status and presence of vitritis. Overall, the clinical diagnosis pointed towards toxoplasma retinochoroiditis. Systemic investigations were largely within normal limits, but toxoplasma IgG came out to be positive. So, considering the clinical diagnosis, empirical treatment for toxoplasma was started. Patient was started on trimethoprim and sulfamethoxazole along with oral prednisolone and oral azithromycin. In view of posterior pole involvement, particularly in zone 1, intravitreal clindamycin was administered to achieve rapid local control and prevent vision loss. So patient was followed up at regular intervals, and at 6 weeks, the lesion had healed with scar formation and the visual acuity improved to uncorrected 6/6 N6 near vision. So the take-home message, timely initiation of appropriate treatment can lead to better visual outcomes. That brings me to my conclusion. Thank you.
Over to the judges.
Thank you, Nikita. What are the chances that this patient is going to come back with recurrence?
The recurrence is high for toxoplasma retinochoroiditis.
What percentage? Are you aware?
60 to 70%.
So how will you treat that?
So in case of a recurrence, the patient can be restarted on the medical management.
And
with
suppose patient has multiple recurrences, what will you do?
In case of multiple recurrences, the intravitreal clindamycin can also be repeated.
Now,
We can
suppose
also
patient
do.
is a high-profile traveler. He says, do something to prevent recurrences. Can you do something?
Yes, ma'am. Prophylactic therapy can be given. So the same therapy, sulfamethoxazole and trimethoprim, can be given once in every 2 to 3 days. This was according to a 2002 study done in Brazil, where they had done it, as well as another study done in 2014, which
So for
also
how
proved the
long
same.
would you give?
In the first study, they gave it up to 20 months. So we can
And
be.
the patient will be recurrence-free forever?
Oh, we cannot guarantee
It's
recurrence
only
free.
as long as he's taking the prophylaxis. Thank you.
Yes, sir.
So, Nikita, yeah, so Toxo was a nice case, treated well with a good outcome. So I have a clinical question for you. Your patient had a RAPD of grade 1 in the right eye. How will you measure a RAPD?
From the RAPD, we can measure it using the swinging flashlight test. And
How?
it can be, ma'am, it can be quantified using the neutral density filters.
Suppose if this patient is not responding to what you put, like, sulfamethoxazole and trimethoprim, then what other regimen would you like to use? Intravitreal you gave in this patient. What are the other antitoxo can be tried?
We can give sulfadiazine, and pyrimethamine is the other combination which can be used in such
So if
cases.
you're giving that combination, what other drug would you like to give it to the patient? If you're using pyrimethamine with sulfamethoxazole.
Pyrimethamine has a side effect of bone marrow depression. It is a folic acid antagonist. So folic acid has to be supplemented on a weekly basis for those patients.
You give folic or folinic
Folic or
acid?
Folinic acid.
What
Folinic
is the
acid.
difference?
Yeah, if you put folic, it will reduce efficacy of the drug. You have to give folinic acid.
Folinic acid.
Great presentation. And the way you guys are at residency, the way you are answering the questions, it's absolutely amazing. Not just you, even the others who came before. So my question is, what is a classical toxoplasma retinochoroiditis lesion?
Sir, a classic lesion, there can be presence of an old scar along with a fresh white fluffy retinitis lesion.
Right. So it's a recurrent toxoplasma retinochoroiditis all the time, right? Did you see a scar here?
No, sir, in this case, there was no scar.
Scar. So how will it change your approach to this patient?
So we can consider it to be an atypical presentation of toxoplasma. So in that case, if the patient did not respond to medical therapy, we can
No,
do
in the
PCR.
diagnosis itself.
Okay.
PCR, I understand. That's a good answer. But what else? You did a serology, right? Did you expect something else in the serology in this patient?
Yes, sir, we did expect IgM to come out to be positive,
Right?
but that was not the case.
Not the case. What about the epidemiological aspect? This patient,
Yes.
coming to you with a primary lesion, right? Primary toxoplasma
Primary
retinochoroiditis. Will you be worried about any? What is the most common mechanism of spread of toxoplasma?
So it can spread, congenital spread is.
Other than that, this patient, what would be the most likely reason? We don't eat so much pork in India, right? So what is the most common cause of spread of toxoplasma?
Exposure to infected animals.
Anything else?
If the vegetarian gets toxoplasmosis, then what could be the source?
Not very sure.
So it's more often the contaminated water
Contamination.
source. Okay, so you have to look for the contamination, and there could be other people, in the family, in the neighborhood, who may have the same infection. And a lot of these patients in whom the infection is in the periphery, and in one eye, they may go unnoticed. And it's only much later you will find scars in those patients. So there's a wonderful study from Madurai by Dr. Manohar Babu on this exact thing, which you should look up. Okay.
Yes.
Last question, and I think you would know the answer. How will the OCT help you in differentiating between toxoplasma, since this is a primary lesion, not a classic lesion? How will the OCT help you?
So the OCT showed us dense vitritis, presence of vitritis, and thickening of the posterior
No, from
hyaloid.
other causes of what will be the main differential?
Any viral
Viral.
causes.
So how will
Yes.
it help you in differentiating from viral retinitis?
So viral causes are usually peripheral and multiple.
No, the OCT. I specifically want the OCT answer. How will it help us?
Full thickness involvement with choroidal backshadowing.
Yeah.
Maybe
So
talks of
what will happen in virus? Viral retinitis?
a choroid will not be involved.
Very good. Anything with the posterior hyaloid?
Posterior hyaloid is
It's a
thickened
more
in
recent report.
toxoplasma.
Anyways, you're doing very well. Thank you.
Thank you.
Thank you, Dr. Nikita. So we just had an engaging discussion, and now we have.
Dr. Vandana, I have a, sorry
Yes.
to interrupt you. I have a question for you.
Yeah.
Were guys
Please
not
say.
allowed to participate in this?
No.
I just checked. So it's
Yeah,
1 to 12, all girls. Well done.
No, we have
You have a guy
guys coming
coming up,
up.
Sonia,
We have
Prashant.
Dr. Prashant Toma
Oh,
coming up.
All the next
sorry.
candidate.
Okay. Oh,
Yeah.
wonderful, wonderful.
Yeah, we have
Thank
and one more. Dr. Prashant, you may begin.
Good evening, ma'am. Am I audible?
Yes, you are audible. You may begin.
So my case is tuberculous choroidal granuloma. A 36-year-old male presented with complaints of diminution of vision in left eye since June 2024, approx for 6 months, when he presented to us, which was insidious in onset, gradually progressive. There is a past medical history of port span, and he was on ongoing ATT for 9 months of duration. Systemic examination was grossly within normal limit. On ocular examination in right eye, distance visual acuity was 6.
Can you share your presentation?
Presentation, it's not seen.
Sorry, sir. Is this visual, sir?
No.
Or you need to click the share button on the screen. First open your presentation, then click share button on the screen.
I've already. Is this visual, sir?
Doctor, can you just click on the share button on the screen, bottom 6 o'clock? It should open a pop-up. Can you see the share button option?
Yeah, I have seen. I have already.
Are you on a Mac?
No, sir. It's window.
Just click on the share button once. A pop-up will come. On left-hand side, you will have entire screen option. Just click on the entire screen and then go sharing. Are you comfortable doing it, or should we have the next person?
So
can continue with the next person. I will present in the end.
Yeah. Dr. Bandana, can we call the next participant?
Yes, sir. Yes, sir.
We'll take
Okay,
Dr.
next
Prashant after 2-3. Prashant, you get ready with presentation and just message.
Right, sir.
Thank you.
Okay. Next we have Dr. Saita Kotapalli. Yes, doctor, you may please share your presentation again.
So good evening, everyone. Are my slides visible, sir?
Yeah, you're live.
So
go ahead.
I'm going to present a case of cloaked-in inflammation unveiling in T-cell intraocular lymphoma. A 56-year-old female presented with diminution of vision in the left eye since 4 weeks. The patient was diagnosed as pan-uveitis outside and blood routine, urine routine, quantiferon TB, serology, anti-CCP, ANA profile, serum ACE, toxo, IgM, Cianca, and all were within normal limits. And the patient was started on topical on oral steroids. And she was a known case of diabetes, hypertension, thyroid, and on medication for that since 10 years. There was no history of redness, photophobia, no history of skin rashes, joint pains, oral ulcers, TB or contact with TB patients, no history of exposure to pets, and no history of trauma or ocular surgeries. On examination, IOP of the right eye is 15 mm HD on applanation, and visual activity of the right eye is 612 improving to 6.6. Anterior segment and fundus examination were completely within normal limits. And this is OCT of the right eye. As you can see, this is completely normal. On examination of left eye, IOP is 18 mm mercury on 80, and visual activity of the left eye is hand movements. Anterior segment examination showed endothelial dusting with diffuse keratic precipitates. Anterior chamber showed flare 1+. On fundus examination, anterior vitreous face cells 2+ and haze 3+. On fundus photo, as you can see, multiple orange subretinal lesions, which is similar to leopard spots. And this is OCT of the left eye. As you can see, there are multiple subretinal hyperreflective foci, and there is a RP undulation, it's an lumpy-bumpy appearance of RPE, and the hyperreflective foci in the choroid, and hyperreflectivity in the internal vitreous. As you can clearly see here, there is RP undulations with hyperreflective foci. So based on the clinical findings, the diagnosis of primary vitreoretinal lymphoma was made, and the patient was referred for neurologist consultation to rule out CNS lymphoma. PET-CT showed no CNS involvement, and the patient was advised to stop oral steroids 2 weeks before the vitreous biopsy. And the patient was underwent vitreous biopsy in the left eye. And this is a video showing vitreous biopsy. We plan to do vitreous biopsy and diagnostic vitrectomy under air. So we started doing vitreous biopsy using 3-port pars plana vitrectomy. As you can see, there is a diffuse infiltration of vitreous and multiple subretinal lesions. So we can go as close to the lesions as possible. So this could increase the yield of the sample, and it was done under air. So after aspirating 1 cc of sample, air was turned on and the entire process was completed under air. So we could obtain more undiluted sample, as this will increase the yield of getting better results. So cytology report confirmed the diagnosis of T-cell lymphoma and positive for CD3 and CD5 positive. And the patient was planned to administered left eye intravitreal methotrexate 0.4 milligrams in 0.1 ml. And this is a fundus photograph of pre and post treatment, which showing complete resolution of lesions with scars. But on follow-up after 3 months, there were few subretinal deposits in superior temporal quadrant was noted with anterior vitreous face cells 2+. And the patient was administered intravitreal methotrexate 0.4 milligrams in 0.1 ml in the right eye according to modified protocol. And these are the pre-treatment and post-treatment photographs which showing resolution of lesions with scarring. Thank you.
Thank you, Dr. Saiteja. Over to the judges.
Thank you, Dr. Saiteja. I have a couple of questions for you.
Ma'am.
You did not show us MRI, did you?
No, ma'am. And like in rules of the competition, they have told not to put photographs or like In that they mentioned, that's why I've removed MRI and cytology report, ma'am. Cytology report also I have.
So when was MRI done?
MRI done, like we have sent to MRI, like after diagnosis, we suspected lymphoma, ma'am. After that, we have sent to neurologist opinion, and that time she came back with MRI report and it was normal, ma'am. No CNS involvement was noted.
So you first had involvement of left eye, then the involvement of
Of right eye, yes, ma'am.
I doubt about the scarring part in the right eye. I think those lesions are sub-RPE deposits.
Yes, ma'am.
Lymphoma does not scar. So between your pre-treatment and now, the lesions are progressing. So I would be very worried. And especially your patient, I don't know how old. I'm
56,
sorry,
ma'am.
56,
56
young
years.
patient. So you do have bilateral involvement.
Yes, ma'am.
So why do you think bilateral involvement is important from patient's perspective?
Like, I think like bilaterality, like more CNS involvement will be there in most of the patients, ma'am.
Absolutely. Bilaterality is not good, and it probably requires systemic therapy and not only the local therapy.
Yes, ma'am.
Bilateral in a 56-year-old,
Role.
I would be. My practical question to you, you did a beautiful vitrectomy, or your mentor did. How do you transport this sample to the lab?
Ma'am, in Hope's media, ma'am.
Which media?
Hope's herpes
What is
glutamic
that
acid.
media?
Herpes glutamic acid medium. Or if like we will transfer within 60 minutes, ma'am. As if we cross 60 minutes, they will under lymphoma cells will undergo morphological degradation. Or in case of delay, we will transfer in 8:1:1 ratio of ethanol, methanol, and propanolol, ma'am.
And where do you send the sample? Who looks at it? What?
Ma'am, pathologist, ma'am. Like if our hospital, like we've sent to one GKNM lab, ma'am. So we'll send there and we'll be in talks with like pathologist.
It may be difficult question for you, but since you are answering so well, suppose you're suspecting lymphoma and your cells are degenerated and pathologist is not sure. Is there something else you can do?
Ma'am, interleukin 10/6 ratio we can do, ma'am. If it's more than 1, then it's lymphoma. If it's less than 1, like more towards uveitis, ma'am.
Very good. Over to you, Padma and Soumya.
So what other test you can do? Cytology is most important. You have to
Yes,
transport it. And you told about interleukin 10/6 ratio.
Yes,
What other tests can be done?
Ma'am, autofluorescence I wanted to do because on fundus autofluorescence, granularity is suggestive of active lymphoma, ma'am. So that would have been done.
That is on imaging, where you have motile typo with hyperautofluorescence will be seen.
Yes.
I'm asking from the lab point of view, what other additional investigations can be done when you're suspecting a case of
Any
lymphoma?
gene mutations, ma'am, MYD88 is mostly positive in these patients.
Sure. So one more, you treated this patient with methotrexate
Yes, ma'am.
intravitreal. Suppose this patient is not responding to intravitreal methotrexate and systemic chemotherapy regimen as well for intraocular lymphoma. What other intravitreal drug you can consider for this
Rituximab, ma'am.
patient?
Intravitreal rituximab will use, ma'am.
What is the dose?
Ma'am, 1 milligram in 0.1 ml.
So when you're giving repeated intravitreal methotrexate, what complications do you anticipate?
Ma'am, corneal epithelial toxicity will come. And this patient also, after giving in the right eye, and the patient had corneal epithelial toxicity, ma'am.
So what drug will you give to
ma'am, we'll
prevent the
give
toxicity?
lubricants, folinic acid will give, ma'am, to prevent the toxicity. Oral
And
folinic.
also, when you're injecting, what technical modifications do you do when you give intravitreal methotrexate?
After injecting, we'll irrigate the ocular surface with BSS, ma'am, balance salt solution, about 150 to 200 ml of BSS will do. Like to prevent the corneal epithelial toxicity.
What other measures? Compared to normal, if you're giving anti-VEGF agent to one patient and you're giving intravitreal methotrexate to the other patient.
No.
You put the cotton plaque and hold it for some time.
Yeah, yes, ma'am.
Yeah,
Yes.
That's a technical modification.
Yes.
Yeah.
Thank you.
Good.
Absolutely amazing. You have all the answers. I mean, wonderful. So
thank you, sir.
One related question about the biopsy. A lot of these patients are diagnosed as uveitis, okay?
Yes.
And someone would have started treatment for the uveitis. So would you take any precautions before doing the biopsy for these patients?
Yeah, sir. We will stop steroids like at least before 2 weeks, sir. If the patient is on steroids and results will be altered, like we won't get.
How will it be altered? What will you see?
Early cases, like it will show positive response with steroids early, sir. But after that, again, it will degrade, like it
How
won't
will it
respond to
affect the
steroids.
biopsy? What will you see on the biopsy?
Like cells, maybe
The cells you're
lymphoma
seeing.
cells.
Cells
Like,
you're seeing, so you want to see lymphoma cells, right?
yeah, sir. Like normally cells are like if in the case of B-cell lymphoma, large with prominent nuclear and all, I think the cell characters will be altered.
So yeah, the steroids will cause a lot of degeneration of the cells. So you'll not be able to reach your diagnosis. Suppose, you did a vitreous biopsy and it's wonderful that you did it under air. I think that was a great idea, and going close to the lesion was also a good idea.
Sir.
But suppose despite doing all of this, you didn't get your, B cells on the biopsy, what will be your next step?
If we are clinically very sure of lymphoma, even if vitreous biopsy is negative, we'll proceed with injections, sir, intravitreal injections.
Anything before that? Of course, I'm assuming that you had the right coordination with the pathologist.
Yeah.
You typically want someone waiting at the door to pick up the sample and rushing to the
Yeah,
pathology.
yes, sir.
So, I mean, that's all assumed. So, despite doing all of this, your vitreous biopsy is negative. Can you do something else before starting the treatment?
CNS.
Where is the primary, before CNS, where is your lesion? You saw the lumpy bumpy stuff, right?
Appearance, yeah, sir.
Can you do something about it?
Autofluorescence.
You're very fond of autofluorescence.
To OCT through the lesion.
OCT through the lesion.
And any other biopsy you can do?
Vitreous tab.
No, you've already done
Would you
that.
like to go?
CNS, lumbar puncture.
Would you like to go subretinal lesions?
No.
No, that's okay.
You have already answered a lot of questions, so don't worry about that. But read
Which
it out.
year of post-graduation you are in?
Ma'am, final year.
Third year.
Third year, yes.
Wonderful. Well done. Keep it up.
Thank
you. Thank you, Dr. Saita.
Thank you. Thank you, ma'am.
Thank you very much. Next, we have Dr. Shini Bhasi. Over to you.
Are my slides visible, ma'am?
Yes, slides are visible. We can hear you.
Good evening, everyone. Today, I'll be presenting the case of a 30-year-old male who presented to us with diminution of vision in both eyes since 1 week, which was sudden in onset, painless, and progressive in nature. The patient had history of fever 5 days back, which lasted for 1 day and was not associated with any rash. There was no history of any systemic illness. At presentation, the best corrected visual acuity in the right eye was 6/60 with an intraocular pressure of 30 millimeters of mercury. There were presence of anterior chamber reaction with a few cells in the anterior vitreous phase. The best corrected visual acuity in the left eye was 6/24 with an intraocular pressure of 28 millimeters of mercury and presence of anterior chamber and anterior vitreous phase cells. On fundus examination, he had mild vitritis with a cup disc ratio of 0.6 and punched out necrotic lesions involving the macula. There were numerous coin-shaped necrotic retinitis lesions involving the posterior pole and the periphery, with a tongue-shaped retinitis lesion in the periphery of the right eye. There were sclerosed vessels with hemorrhages nasally. The OCT of both the eyes showed presence of hyperreflective foci in the posterior vitreous phase, with the hyperreflective retinal layers and loss of inner retinal layers sparing the internal limiting membrane. There was also presence of intraretinal edema and presence of subretinal fluid in the right eye. The fundus fluorescein angiography of the right eye showed staining of retinitis lesions, vascular leakage involving both the arteries and the veins, and a hot disc. There was also presence of blocked fluorescence corresponding to the hemorrhages and a peripheral avascular area nasally. Similarly, the left eye showed a hot disc, macular staining, and staining of the retinitis lesions. ICG of the right eye showed chirales arteriolitis, and there was no significant finding seen on the ICGA of the left eye. So we performed ancillary blood investigations, all of which were within normal limits, with a negative HIV, TPHA, and VDRL. So we made a differential diagnosis of viral retinitis secondary to acute retinal necrosis, or atypical CMV, and SSPE. On further asking, the history of immunization status was not available. However, there was no history of convulsions, behavioral changes, or loss of consciousness, and the patient was advised to undergo serum and CSF measles antibody test. Keeping the differentials in mind, the patient was started on val-acyclovir 1 gram TDS with topical anti-glaucoma medications, steroids, and cycloplegics. These are the serial fundus photos of the patient over the course of treatment. Even after starting the patient on antivirals, new retinitis lesions cropped up as seen along the superotemporal arcade, and there was also an increase in the cellular reaction in the anterior chamber. The patient was then advised to undergo AC tap for viral PCR and was given intravitreal ganciclovir along with prophylactic laser to the retinitis lesions. And oral val-acyclovir dose was increased to 2 gram TDS along with half dose of oral steroids. A second dose of intravitreal ganciclovir was given. Meanwhile, the PCR result came out to be negative for HSV1, 2, and CMV virus. Varicella zoster virus PCR was not available. Similarly, in the left eye, the patient was injected with 2 doses of intravitreal ganciclovir, and prophylactic laser was done to the retinitis lesions. His serum measles IgG was positive with a value greater than 300 AU per ml, and the CSF measles IgG levels were 553 AU per ml, giving a CSF by serum quotient of 1.8. We performed further investigations like MRI brain and EEG, both were within normal limits. His CD4 counts and immunoglobulin levels were also within normal limits, and serum dengue NS1 antigen came out to be negative. So we reached to a diagnosis of bilateral measles-associated necrotizing retinitis with secondary ocular hypertension. Unfortunately, 6 days after the second dose of intravitreal ganciclovir injection, the patient presented with right eye vision of perception of light, with hypopyon and AC and severe vitritis noted on B scan. The patient was planned for right eye vitreous biopsy with pars plana vitrectomy and intravitreal antibiotic with silicone oil insertion the same day. The left eye was stable with a vision of 6/18. The patient had to undergo multiple surgeries in almost 2 months' time with oil fill and a stable retina at around 9 weeks on treatment. He was then planned for silicone oil removal. The OCT showed resolution of edema with loss of the retinal layers at the macula and an intact inner segment-outer segment junction. The patient has been on follow-up with us since more than 1 year with no neurological complaints or behavioral changes. The vision in the right eye has improved to 6/36 with a cup-disc ratio of 0.6 on topical anti-glaucoma medications. The OCT further shows further restoration of the ISOS at the macula. The left eye has been stable with a slight improvement in vision to 6/12. Thank you.
Thank you, Dr. Shani. Ma'am, over to you for the questions.
Thank you, Shiny. Very interesting case. Your SSPE, OCT, that ILM drape sign and the loss of retinal, it's very typically SSPE. What bothers me are the peripheral lesions. You have very extensive peripheral involvement. And the other paradox was like your CSF showed local production of antibodies compared to serum. They were elevated, but EEG was normal. One of the highlight of measles virus is abnormal ectopic responses on EEG. I don't think antivirals truly work for SSPE. Interferon therapy is given, and prognosis is really bad even for life. That's all I have to say.
Yes, Shaily's challenging case. It's very difficult to diagnose, and clinical features, like ma'am said, it's not only classical central retinitis, it had extensive peripheral involvement. Yes, you need to counsel the patient for the guarded prognosis and closely watch him.
Yeah, a wonderful case and very well investigated. I was also concerned about the continuous use of valacyclovir, knowing that it will not be working for measles, and when you have got such good evidence of measles. Okay. By the way,
So
is
actually
measles?
we
Yeah,
received
go ahead. Yeah, sorry, go ahead.
So we received the reports for the serum and CSF antibody later. So we started the patient prophylactically on valacyclovir and ganciclovir because we suspected acute retinal necrosis earlier, and it was a significant DD. So delaying the treatment could have resulted in worse prognosis. So that is why we started the
No,
patient on the
that's
treatment.
in the beginning, but you're continuing in the end also, right? I thought I saw valacyclovir towards the end.
Sir, actually, when we gave the second dose of ganciclovir injection, that is the time when we received the measles antibody test results. So after that, we did not give the patients,
Okay.
but he developed complications because of it. So we had to treat them.
Okay. All right. By the way, is measles a DNA virus or an RNA virus?
RNA virus, so
Good.
single-stranded RNA virus.
So how do you prevent it? How can we prevent?
Ma'am, vaccination should be given. And in
What
the developing
vaccine?
countries, ma'am, MMR vaccine.
At what age it is given?
Ma'am, MMR vaccine is given at 6 months and then at 24 months.
Not sure.
Okay, thank you, Dr. Shiny. Next, I think we can have Dr. Prashant Tomar back. Dr. Prashant, are you ready?
I'm ready, ma'am.
Yeah, okay. Please share your screen. Okay.
Is screen is shared, ma'am?
Yeah, it's visible. You can start presenting.
Good evening, everyone. My case is tuberculous choroidal granuloma. A 36-year-old male presented with complaints of diminution of vision in left eye since June 2024. It is around 6 months when he presented to us. It was insidious in onset, gradually progressive and painless. There is past medical history of port spine, and patient was on ATT, ongoing ATT when he presented. And there was systemic examination. There was grossly within normal limits. And ocular examination, right eye distance visual acuity was 6/6 and unaided. And left eye distance visual acuity unaided was 636, which was improving to 680. The rest other anterior segment findings of both eyes were within normal limit. And fundus examination of the right eye shows small yellowish lesion located 5 disc diameter away from optic disc, temporarily at 9 o'clock position. Margins were fuzzy and retinal vessels visible overlying the lesion. And the fundus examination of the left eye showed macular lesion located 4 disc diameter away from optic disc, temporarily at 9 o'clock position. Size was approx 3 disc diameter and margins were fuzzy and retinal vessel visible overlying the lesion. So it's signifying the lesion is choroidal in origin. Fundus autofluorescence of the right eye showing the hypoautofluorescence choroidal lesion with the surrounding hyper autofluorescence rim suggestive of active RPE stress consistent with choroidal tubercle in the right eye and larger granulomatous lesion in the left eye. OCT overlying the lesion in the right eye showing the choroidal hyperreflective mass causing elevation of the RPE and brush membrane complex with the outer retinal disruption. The right eye showing the small dome-shaped elevations suggestive of choroidal tubercle, while left eye showing the large choroidal mass with subretinal fluid consistent with the choroidal granuloma. FFA of the right eye showing the normal vascular filling with preserved FAZ, and this is the early, mid, and late phase showing. And the lesion is showing the posterior pole showing the progressive late leakage suggestive of active inflammatory choroidal tubercle. And FFA of left eye early phase showing hypofluorescence round lesion temporal to the disc. Mid phase showing the patchy hyperfluorescence with marginal staining. and in the late phase showing progressive hyperfluorescence with diffuse leakage and staining. So patient was on ATT and was on tapering dose of the steroid, but we again started prednisolone 60 milligram OD, calcium and pentop, and patient was administered 4 doses of intravitreal injection Rajumab. And this was the fundus finding and the OCT finding post intravitreal injection, post 1 month intravitreal injection, and we can see that distance visual acuity also increased up to 6/9. And in this OCT, we can see that left eye with intravitreal Rajumab showing significant reduction in the subretinal fluid, decrease in the height of the choroidal granuloma, and improve in the retinal architecture. And there is partial restoration of the foveal counter also there, but there is some residual RP irregularity is present, can be consistent with healing granulomatous inflammation. And so this is the pre-treatment or post-treatment OCT we can see here. And take-home message is multimodal imaging guided diagnosis with ATT, steroid, and adjunct anti-VEGF can effectively manage ocular TB presenting as choroidal granuloma and can prevent the vision loss. Thank you.
Thank you, Dr. Prashant. Over to the judges.
Soumya?
Yeah, so very interesting case, especially knowing that the patient had already received 9 months of ATT for the pot spine. My question is, when the patient presented to you, was there pain in the left eye? Did the patient complain of pain in the left eye?
No, sir, there was no pain. No, sir.
No pain.
Only there was symptoms of blurring of vision.
Okay.
The patient was not completed the ATT. Actually, he was ongoing ATT.
Right. Suppose the patient had complained of pain in the left eye, what would you have suspected with the same clinical picture that you saw?
Sir.
What would you suspect if there's pain also in the left eye?
If pain is present along with it, it can be involvement of the anterior segment, so it can consist with anterior uveitis.
But you have seen there was no anterior. I am saying exactly the same clinical picture, but the patient is also complaining of pain.
With a similar.
What other posterior structures can get involved? Into the choroid.
Posterior side, so the choroid can be involved, retina can be involved.
But choroid and retina do not have pain receptors,
even
right?
It can.
Outside choroid?
No pain receptors, sir.
Outside.
So in intermediate uveitis,
Go outside choroid. What is the structure outer to choroid?
Iris. Iris and ciliary body.
Which is the outermost coat of the eye?
Uveal tissue is the middle coat.
Middle coat.
Which is the outermost?
Most.
White in color.
No, don't worry. It was a wonderful case, but we are asking you about the sclera, right?
Sclera, sir, sclera.
So if
scleritis can, yes, sir. If patient presented with scleritis,
And
nodular
how
scleritis usually present.
Yeah, so this patient, exactly the same clinical picture, has come with pain. How will you verify that the patient also had a scleritis along with whatever you are seeing?
Sir, patient will present with a nodular type of scleritis.
No, exactly the same picture, what you have seen. Suppose there is a scleral involvement as well. How will you diagnose it? What imaging will you use for that?
you want to check whether the sclera is involved or not. Or in other words,
ultrasound can be done.
What will it show?
It will show the lesions.
In scleritis, what sign do you expect on B-scan? If the fluid in the subtenon space, how will it look like?
In subtenon, I'm not sure.
Suppose you're giving anti-TB drugs. The patient is coming with sudden decrease in vision. You're not seeing anything new or extra on the fundus. So what or the DD you would like to rule out? Or what do you suspect?
In this case, it can be toxoplasma associated. It can be.
Major Tomar, what they are trying to say is many a times TB also produces immunological responses. Since your patient is already on anti-TB drugs, there could be posterior scleritis, which is more of an immune-driven mechanism. So a very important clue is the pain. If this patient is having pain, that itself is a marker that it could be posterior scleritis rather than a pure choroidal granuloma.
Right.
Thank you, Dr. Major Prashant. Next, we have Dr. Swikriti Kothari with the next case today. Dr. Swikriti?
Yes, am I audible?
Yes, you are. Please share your screen too.
Is my screen visible?
Yes, you're visible. Okay.
May I start?
Yes, you may start.
Good evening, everyone. I'm Dr. Swikriti Kothari, and I would like to go through inflammation superimposed on a genetic canvas, and a case of autoimmune retinopathy in a patient with inherited retinal dystrophy. So, a 38-year-old gentleman presented to the OPD with complaints of progressive diminution of vision more in the left eye than the right eye for the past 3 months. He also had a significant increase in difficulty in night driving for the past 3 months. There were no symptoms of ocular pain, redness, flashes, or floaters, and he had no systemic complaints as well. A few important things to note from his history were he had a history of myopia since childhood. There was mild difficulty in night vision from a young age, and his younger brother also had a history of difficulty in night driving. But these symptoms had accelerated over the past 3 months. There was no history suggestive of uveitis or systemic autoimmune disease. He was diagnosed elsewhere as having a rod cone dystrophy. On clinical examination, his best corrected visual acuity in the right eye was 6/9 for distance and N6 for near. In the left eye, 6/15 for distance and N6 for near. On slit lamp examination, his anterior segment was within the normal limits in both the eyes. On fundus examination, both the eyes had a pale disc and vitreous condensation and membranes were visible. There were retinal pigment epithelium alteration with washed out appearance as can be seen. There was pigment clumping in the periphery and mild vascular attenuation. All these changes were more in the left eye as compared to the right eye. On fundus autofluorescence, there were hypoautofluorescent areas. Robson-Holder-like line was visible. We did a swept source OCT for the patient, and as we can see in the right and the left, both the eyes, there was loss of ellipsoid zone with thinning of the outer retinal layers and changes in the retinal pigment epithelium. On 120 suprathreshold Humphrey visual field screening test, we could see equatorial scotoma with relative central and peripheral sparing, more on the left side than on the right side. We did an electroretinogram for the patient, and it showed decrease in photopic responses, decrease in scotopic responses, decrease in photopic responses, and overall retinal dysregulation was seen. So basically, with the rod cone dystrophy, the following features were basically atypical from our expectation. One was the adult onset with a rapid recent progression. There was asymmetric involvement, left eye being involved more than the right side. Visual field pattern also did not show ring ring scotoma. It did not show ring scotoma. It showed an equatorial scotoma with relative central and peripheral sparing. ERG responses were reduced, but they were recordable. So there was basically a structure function mismatch on multimodal imaging. That is, the fundus photo and the imaging modalities showed more changes as compared to the changes in his visual acuity. So we did a genetic testing for the patient, considering the patient was born of a consanguineous marriage and his younger brother also had similar complaints. We did a next generation sequencing panel for inherited retinal disease, and findings were supportive of an underlying inherited retinal dystrophy. But these genetic results did not explain the rapid progression or asymmetry that the patient presented with. So we were suspecting autoimmune retinopathy as well. We did an autoimmune retinopathy workup, and multiple anti-retinal antibodies turned out to be positive. The patient's blood sample was taken, and the antibody workup was positive for aldolase, enolase, arrestin, tubulin, pyruvate kinase M2, and glyceraldehyde 3-phosphate dehydrogenase. So we came to a final diagnosis of genetic retinal dystrophy with superadded autoimmune retinopathy. We gave oral corticosteroids to the patient, and methotrexate 15 milligram per week as a steroid-sparing immunosuppression was started. Regular monitoring was done with visual acuity, OCT, autofluorescence, and visual fields. The outcome: subjective improvement in visual symptoms. His best corrected visual acuity improved from 6/9 in the right eye to 6/7.5 and 6/15 in the left eye to 6/7.5. There was stabilization of visual fields on follow-up, and no further progression was noted on OCT and fundus autofluorescence as well. Thank you so much.
Thank you, Dr. Srikriti. Over to the judges.
Thank you, Srikriti. That was a tough case for everybody. What were your criteria for diagnosing autoimmune retinopathy?
Ma'am, it was the patient presented with specific 3 months of complaints, sudden or insidious onset, we could say, and also there was a structure function mismatch. The fundus that we could see did not correlate so well with the visual acuity. Like, the patient's visual acuity was still better as compared to the fundus changes and other changes on imaging. So these features pointed as an atypical feature of a rod cone dystrophy. But considering that the patient already had a history of difficulty in driving in the night, and since a young age, difficulty in night vision, but this had accelerated in the past 3 months, and younger brother also had a similar history.
No, I have no doubt about the rod cone dystrophy, and there were few asymmetric changes, and there were few features which were atypical. Fair enough. But
Yes,
my
ma'am.
thing is, how did you define autoimmune retinopathy? What was like your definition for autoimmune retinopathy, not for rod cone?
Okay. Ma'am, so the patient presented with sudden onset features, and
Because if you want to say that you thought there was some autoimmune process going on, that's something very different. But when you say autoimmune retinopathy, that's a very different entity altogether, you know? So
yes, ma'am.
how did you reach the diagnosis of autoimmune retinopathy? I can understand if you can't answer, because it's okay. But in case you can, I would love to know.
Ma'am, the ERG response was also
Oh, not truly.
okay.
Not really. Anyways, that's it for me.
Yeah. What are the causes for, like, one, you have retinal dystrophy, and the one is autoimmune retinopathy, you will have anti-retinal antibodies. What are the other causes, or where do you get false positive anti-retinal antibodies on testing?
Ma'am,
it must be too high for the PG level, but if you know your answer, otherwise we'll move on to the next.
Ma'am, probably Azure.
Okay.
I'm not sure, ma'am.
How do you differentiate Azure from the case what you presented? What are the differentiating points?
Ma'am, so Azure would usually have the Azure would present with a better fundus picture. The fundus would not be so much involved. There will also be photopsia is a very significant clinical feature, and there will be a trizonal pattern seen on the OCT.
Trizonal on OCT or on autofluorescence?
So, ma'am, on autofluorescence, there will be a few hyper-reflective foci.
Have you done test for syphilis in your patient?
Ma'am, no, we haven't.
I would do that. Okay.
Okay, ma'am.
So before
Okay.
labeling it as autoimmune retinopathy, if you're suspecting that something is going on top of rod cone dystrophy, I would always test for syphilis. But
okay.
Yeah, Soumya.
Yeah, so actually my question is very similar to Dr. Padma's question. She was asking about false positives. So false positive by definition would mean that you're getting it positive when it's not there. But my
Yes, sir.
question is that suppose you do testing for anti-retinal antibodies in healthy individuals who do not have any other disease. What do you think are the chances that you will get positive tests in healthy individuals? Difficult for you, but since it's looks so stark, a whole bunch of anti-retinal antibodies, everything seems to be positive, and you are so forced to take up that diagnosis that this is autoimmune retinopathy. When the other features are not fitting into it, the ERG definitely is not fitting into autoimmune retinopathy. So, I would suggest look up this point. What is the prevalence of anti-retinal antibodies in healthy people? There are good studies on that. Okay. But I mean, you answered very well so far. So well done.
Thank you, sir. Thank you.
Thank you, Dr. Swikriti. And we are kind of nearing the end of our session. We have one last candidate. I invite Dr. Vaishnavi Shyam Mahajan to present the last case for the day. Okay, Dr. Vaishnavi, we can't hear you. You're on, okay, yeah, okay.
Dr. Vaishnavi, you can start, please.
Yeah. Good evening, everyone. Today I'll be presenting a case of a 48-year-old male who presented with the chief complaints of sudden onset pain in right eye since 3 days, diminution of vision, which was insidious in onset and gradually progressive, and floaters in right eye since 3 months. He was also treated for toxoplasmosis with a tablet cotrimoxazole double strength and oral steroids for a period of 1 month, 3 months ago. And on further probing, he also revealed that there was a history of weight loss in the past 6 months. On examination, the best corrected visual acuity in right eye was perception of light, and in left eye, 6/6 on Snellen's chart. On mutton fat, keratic precipitates were present on endothelium in both the eyes. In right eye, cells +3 cells and +1 flare was noted in the anterior chamber with no iris nodules and cataract. On pupillary examination, relative afferent pupillary defect grade 2 was noted in the right eye. On fundus examination, media was hazy, disc was hazily seen, foveal reflex was absent, and we could see yellowish, whitish yellow retinal discoloration, which was obscuring the retinal vessels and extending to the macula with foveal involvement, and along with an involvement along the superiotemporal and inferotemporal arcades, with few isolated lesions were also noted in the superior quadrant, with no obvious retinal hemorrhages, and no lesions were noted in the far periphery. In left eye, media was hazy, with the cup disc ratio was not made out, foveal reflex was absent. We could see a similar yellowish white discolorated lesion in the peripapillary area with a similar lesion in the superiotemporal quadrant with the area of central clearing. On ocular coherence tomography scan of the right eye, we noted there was a posterior hyaloid thickening, altered foveal contour, inner retinal layer hyperreflectivity, few hyporeflective spaces in the outer nuclear layer, and choroidal elevation was noted. In the scan in the left eye through the disc, we noted there was inner retinal hyperreflectivity with a neurosensory detachment. After investigations, we came to a diagnosis of a bilateral multifocal retinochoroiditis with the differentials of following etiological diagnosis. Toxoplasma retinochoroiditis was considered in view of inflammation in the anterior chamber and vitreous, presence of inner retinal involvement, absence of hemorrhages, and thickening of the posterior cortical vitreous on the OCT scan. Syphilis was also considered since it is a very common cause of necrotizing retinitis. Granular variant of cytomegalovirus retinitis was also considered, though the picture was not in favor, considering lack of hemorrhages and lack of vascular involvement. And when patient presented to us, he also had following investigations which showed toxoplasma IgM was negative and IgG was positive. Considering that though most of the features were in favor of toxoplasma retinitis, typical features of toxo, which usually presents as a unifocal retinitis with significant vitreous inflammation. But in this case, the lack of these typical features prompted us to evaluate for immunocompromised status and to look for alternate etiologies. So we had considered further evaluation, and on further evaluation, HIV 1 and 2 was positive with low CD4 count of 76, VDRL was negative. We then did a diagnostic vitreous biopsy in the right eye, and left eye intravitreal clindamycin 1 milligram was injected. The PCR came back positive for toxoplasma, negative for cytomegalovirus, herpes simplex virus, varicella zoster virus. Bacterial and fungal culture also came back negative. So the final diagnosis of an atypical toxoplasma retinochoroiditis and immunocompromised was made, and the patient was started on antiretroviral therapy, tablet cotrimoxazole double strength 2 times a day, tablet azithromycin 500 milligrams 2 times a day, and topical prednisolone eye drops 1% 6 times a day in weekly tapering dosage. On further follow-up at first week, the best corrected visual acuity was PL positive. We could see there was healing of the retinitis lesions with reduction in size. A similar regression of lesions was also noted in the left eye with resolving retinitis. Further subsequent follow-up on 4 weeks, we could see a resolution of the lesions in the right eye, and similar regression was also noted in the left eye along with scarring of the lesion. The left eye OCT scan at 4 weeks also showed resolved inner retinal layer hyperreflectivity and resolution of the subretinal fluid. At 6 weeks, the patient developed retinal detachment in the right eye. He was given an option for surgery, but he denied any intervention in right eye in view of poor visual prognosis. So a patient is on regular follow-up for every 4 months, and in the last visit, which is now 5 years after the clinical presentation, left eye, the best corrected visual acuity is 6/6, and he's maintaining good vision. Right eye developed complicated cataract with no perception of light. Thank you.
Thank you, Dr. Vaishnavi. Over to the judges, please.
Very nice case. It documents how toxo can present atypically, and especially when you see atypical lesion, HIV would always need to be ruled out. It's very well documented.
Thank you.
I have no further questions. My only question, when will you start heart therapy?
Now, he was not diagnosed before. When he came to us, because of his atypical involvement, we had considered further evaluation. So as soon as we diagnose, we should start.
Sometimes when there is an infection which is positive, they give first few weeks of anti-infective therapy and then introduce heart, So your infection management is very important. And it will also influence the duration of treatment, whether it is toxo or whatever treatment, TB or whatever. The duration you will have to be in touch because it's a long-term treatment now, not only for ocular. Very nice.
Nice case, Dr. Vaishnavi. Did you look out for CNS toxoplasmosis in this patient? Did you
In
screen?
immunocompromised states, they have very high risk of encephalitis, but he showed no symptoms of any CNS involvement, so he was not.
Yeah, one more thing. This is extensive involvement with less vitreous. Definitely, it's seen in atypical presentations and immunocompromised. So you are not considered using CNS toxoplasma regimen, like increasing dose of the Bactrim DS in this patient?
He had no signs of CNS involvement, so we had not
Now,
considered.
sometimes when you have extensive involvement in immunocompetent, you can step up the dose of Bactrim DS to CNS toxoplasmosis regimen, and they respond better.
Thank
That
you.
can be considered.
Okay.
Very interesting case. One question which I asked to another candidate some time ago, which are the OCT features here which will make you suspect toxo ahead of the other differentials that you presented?
Posterior cortical thickening, that is important. In those areas, it will be adherent to the underlying retinitis lesions. Inner retinal layer hyperreflectivity and choroidal elevations, if there is any, we should look out for in retinochoroiditis.
Nice. Now the tricky question, okay? Why do you think toxoplasma retinochoroiditis is relatively uncommon in HIV patients as compared to viral retinitis? Relatively, I'm not saying it's rare, but it's relatively uncommon. More often you'll come across CMV retinitis, right? Or maybe ARN. But toxo is relatively uncommon. So there is another infection for which HIV patients are often started on prophylactic therapy, which helps in toxo as well. We don't discuss uveitis due to that infection very commonly, but the treatment of that infection is the same as the treatment which you gave for toxoplasma.
One more clue that infection can be diagnosed commonly following LP.
Cryptococcus.
Close enough. Cryptococcus is a, what is it? Is it a bacteria or a
No, it's a
fungus, right? So
Affects commonly the lungs.
okay.
It's okay.
Look it up.
Yes,
Well
sir.
done. Thank you.
Thank you, Dr. Vaishnavi. And so we have come to the end of our session, a truly exceptional event. Before we wrap up, may I please invite the judges for any concluding remarks? Dr. Vaishali, ma'am.
No, I would like to congratulate all of you. I think exercise like this requires lot of work, starting with 107 cases, reaching up to 12. It would be, I can understand a lot of people have devoted their time and effort to it, and I think they need to be complimented. And secondly, I felt very proud at the standard of post-graduation education in our country. Really, really proud. They were super smart, confident. I mean, talking about mid 88 and all those things, it was amazing. Talk so everything. So I think all of them are going to, I mean, our country is in safe hands. That's all I can say. Congratulations, all.
Soumya.
Yeah, same thing. The fact that 107 people sent in their abstracts itself is a big deal. And, all congratulations to you, of course, led by Partho, that, we could drive so many people to send in abstracts, and then all the hard work that you did to process it to this stage. And of course, the quality of the presentation, it's not just the content, which was, of course, top-notch. The answers were top-notch. But the way it was presented, it shows the seriousness in the effort. And that is very important, that they are taking this very seriously. Even a few years ago, I don't think we were seeing such good PG presentations, in any forum. So huge congratulations to everyone who presented today.
Partho, sir.
Oh, I have no comments. I think they have summarized really. I told no. I think 19, and that day I was watching in two monitors. And it was like amazing presentation. We'll take a group photo. Sunilji, can you help us? Ask everyone to just switch on the video. Ask others.
Can we have all the PGs switch on the cameras? Yeah.
Sunilji, can you take?
Yes, sir.
Yeah. Others, all yes.
God forbid if I had uveitis, I will go to any one of these.
Yeah, Sudarshan sir.
Sudarshan, is SS phone?
Yes.
He's chatting with me on WhatsApp.
Yeah. Okay, well, Sunilji, take one group photo.
Ji, sir.
There he is.
Yes. Thank you.
Thank you, everyone. Very best wishes for your career, and it was a pleasure.
Thank you so much.
Thank you, ma'am.
Thank you so much, ma'am.
Thank
you, everyone. Wishing you all the very best.
Padma, bye Partho, bye
Bye.
Soumya.
Thank you, ma'am. Thank you, Dr. Soumya.
Bye Vandana, well
Thank
done.
you, Dr.
Bye,
Partho.
bye, ma'am. Bye,
Dr.
ma'am.
Vandana.
Yeah. Thank you, ma'am.
Thank you, Sunilji.